Ms. Sukers and Mr. Siwela. Mr. Siwela is attending another meeting and will join this one later. Thank you, Chair.
Thank you very much, Ms. Majalamba. Honorable members, I would also like to just call a very short moment of silence on hearing the news of the passing of the chairperson of the National Committee on the Confidential Inquiry into Maternal Deaths, Professor Eddie Matlanga. Professor Matlanga was a dedicated public servant in the health sphere, and he has done so much work in terms of maternal health in South Africa. So I would really think we need to honor him at this moment with just a 30 seconds moment of silence. Thank you. Thank you very much, honorable members. We are also coming almost to a close of the NHI public hearings, all the oral presentations. We have received 99 oral presentations to date. We were hoping to complete by next week, Wednesday. So we're planning on having these hearings today, tomorrow, Tuesday, next week, and Wednesday. There might be a situation where we might have a postponement or two, which would mean that we'd probably be ending on the 22nd or the 23rd of February. So you have received PowerPoint presentations, and we will receive today from those who then send those PowerPoint presentations. And we must thank our Committee Secretary, Ms. Majalamba, for the good work that she does to forward this to us on time. And honorable members, we will be receiving these presentations today from the NOSA, Young Nurses in Daba, Genetic Alliance South Africa, South African Clothing and Textile Workers Union, People's Health Movement of South Africa, Master Builders South Africa, Professional Providence Society. So with that having said, and you having had an opportunity to read those presentations, we'll go straight into it. But just to commend ourselves on one other point, and that is, you will remember that this portfolio committee was the very first portfolio committee in Parliament that started with these virtual meetings. We were at the forefront of initiating this process in our National Assembly, so we can feel very good about it as we are now coming close to the end of these public hearings. We are presented, Honorable Van Staden, I see you have lowered your hand.
Thank you, Chairperson. Now, I just want to let you know, with your permission, I will leave this meeting by 12 for a meeting I'm having at 1 o'clock. But when I come back from that meeting, I will log in again into this meeting. Thank you, Chair.
Thank you very much for informing us. So, honorable members, we will go straight on to our first presentation, which...
Chairperson?
Yes, Honorable Sukacha.
I'm sorry, I've also raised my hand. I'm sorry, Chair. I just want to indicate, Chair, when we come back from lunch, I see our lunch is from 2 to 3:30. I might be late for half an hour. That is from 2:30 to 3 o'clock. I will be picking up my kids from school, so I might just be late for half an hour after lunch. Thank you very much, Chair.
Thank you, Honorable Sukacha. Just let me correct you there. So, on your latter half, you said it correctly. In your first half, you said it wrongly. Lunch is from 2 to 2:30, and you will be late for half an hour from 2:30 to 3 o'clock. That's what I understand you to say.
Yes, that's correct, Chair.
Thank you. Honorable Clerk.
Thank you, Chairperson. The same with me. I might be late after lunch. I have a meeting at 2 o'clock that I must attend, but if we get finished by 2:30, then I will join. Just your indulgence if I'm late about 10 minutes. Thank you.
Thank you very much. Also be aware, honorable members, that we might just be a little bit ahead of ourselves if the situation does allow us. Since we are
My
aware,
hand is up, Chair.
since we are,
My hand is
I'll take you now,
Chairperson.
Honorable Dr. Temakwayo. Since we will be in these meetings, we expected to be in this meeting until 19:30 tonight. So we would see how we can move a little bit faster when the opportunity does arise. Honorable Dr. Susan Temakwayo. Honorable Dr. Temakwayo.
Thank you, Chairperson. I was just saying I would like to let you know that I'll also be traveling in the late afternoon, but when I arrive, I'll rejoin the meeting. Thank you.
Thank you very much. Honorable Gela.
Thank you very much, Chairperson. I'm also facing the challenge. Leaving the children around the case, but I will rejoin the meeting after lunch. I apologize.
Thank you, Honorable Gela. Honorable members, anyone else? If not, we will go straight into the presentation by the NOSA, who will be led by Daniel Manamela. You can show yourself and then introduce your team and continue straight on with your presentation. Thank you.
Good morning.
Excuse me, Mr. Manamela. Let me just remind everyone to please switch on your video cameras, including the members and the presenters. Thank you.
Thank you very much, Chairperson and honorable members. I'm sure that I'm joined by the president of DINOSA. Maybe I will give him first the opportunity before I start with the presentation. Thank you, Chair.
Honorable Chairperson, thank you very much. And we want to thank the opportunity provided to us by this honorable committee and thank the honorable members of the committee. We came here, I'm leading the delegation of DINOSA. It's me, the president of DINOSA, Simon Hlungwane, as well as the deputy president of DINOSA, Rita Tandegamsibi, as well as Daniel Manamela, who is the deputy general secretary, and Miss Fina Sitsedi, who have come here to join this meeting, but make a presentation. Mr. Manamela is going to make a presentation on behalf of DINOSA in our input. Thank you very much, Honorable Chair.
Thank you very much, Chair and honorable members, and the president of DINOSA, Comrade Simon Hlungwane. In respect of time, I'll just zoom straight to our presentation as has been forwarded to the committee. Can we move to the first slide? As DINOSA, as the president of DINOSA have already said, we welcome the opportunity to present our inputs and to add our voice before the closure of oral presentations to this committee. And we also welcome the release of the National Health Insurance Bill released in July 2019. And as DINOSA, we also say we support the NHI bill in terms of its intended objectives and can't wait for its full implementation come 2026. And we also said DINOSA recognized the fact that it took countries longer than they envisaged to phase in universal health coverage. In our case, the National Health Insurance. And we're saying as DINOSA that there's been a lot of documents that gather dust after they've been signed. Because as far as we are concerned, the period between 2017 and 2022, where we are now, as far as we are concerned, has been very, very mute. So we will highlight the various areas in the bill that seem problematic, but as well will provide alternative proposals to strengthen the bill. Can we go to the next slide? Most parts, in fact, we are covered in terms of most parts of the bill itself. So as I said in the previous slide, that will only highlight the areas that we think will strengthen the bill itself. The first one that we think needs to be included will be the definition of the national health insurance, because many people might interpret it in many ways if its definition is not provided for in the bill. I'm not sure if it is there in the policy document, but in the bill, it needs to be there as far as we are concerned. And the other definition that we think should be included is the complementary health benefit services, where it means health benefits that are not covered by the NHI. And we feel that those benefits need to be clarified, which ones. This is to ensure that the user benefits as much as possible from an increased quality of life. And the other definition that we think should be included is the definition itself of the universal health coverage as defined by the WHO. As I said, that it might be maybe defined in other documents like your policy document, but in the bill itself is missing. So we would like it also to be defined as per WHO definition. Can we go to the other slide? In the third slide, we are saying chapter 1, purpose and application of the Act. The application of the Act, this Act applies to all health establishments, excluding military health services and establishments. But our comment in that respect is that evidence shows that the private health sector is well funded through private schemes, while the public sector is depleted with resources. But services most of the population. We say in the public sector services most of the population. And in this, we want to address the issue of equalizing equality of healthcare services, or the distribution of the resources in the healthcare system itself. So we propose a clear regulation on this implementation. And the rationale is that resources and capacitate public health establishment in order for it to be compliant, but as well compete equally or above the private sector in terms of providing service that is affordable, safe, and that one of quality. That is what I said, that the distribution of resources seem to be a problem in terms of, and as well, the capacity of the public health servants. Can we go to the next slide? In terms of this slide, Section 4A identifies who will be covered by the fund, and Section 2A reads thus: an asylum seeker or illegal foreigner is only entitled to the two, which is emergency medical services, and B, services for notifiable conditions of public health concern. Our comment in this respect is that if there is any act that is in conflict with the Constitution of the country and the Public Finance Management Act, the state, or the state should really look into that closely, so that going forward, the country doesn't face many legal suit from several fronts that may delay the implementation of the national health insurance. So as DINOSA, we say, we propose a thorough and intense legal intervention and consultation in beefing up this argument as said above. Can we go to the next slide? Subsection 2, an asylum seeker or illegal foreigner is only entitled to as well, A, emergency medical services, and B, services for notifiable conditions of public health concern. Our comment is that for this subsection to find manifestation, what mechanism will be used to identify the illegal foreigners for registration processes, to gather information, data about them, for them to be catered for services, and bearing in mind the planning and sustainability of the fund. So we're just raising a question there. But at the same time, like what we said before, is that we don't want to see the state being entangled in legal suit, taking longer, so that when that time comes for the implementation, we find ourselves entangled and delay the full implementation of the national health insurance itself. So our proposal is that there must be proactive measures that are put in place for this matter. And DINOS understand and appreciate that South Africa has entered in many international treaties that bind the country, but the South African government has to also strengthen international laws to be able to govern and protect all persons living in this country. Quite aware that the citizens of the country have got the right to health, and although the national health insurance, the fund itself might be mandatory to its citizens, but considerations should also be taken when it comes to the foreign nationals. So the comment is that the section uses word interchangeably, for instance, refers to illegal foreigners and to illegal migrants. Our proposal is that if these words means one and the same thing, consider to use one word. If they mean different things, provide their definitions, as it is not provided for both in the definition section. The rationale is that utilization of the same word provided clear understanding, and it may eliminate confusion that may arise. Can we go to the next slide? Section 7, 2A in brackets, a user must receive the healthcare services that he or she is entitled to under the Act from the healthcare service provider or health establishment at which the user had registered for the purpose of receiving those services. Our comment is that the underlying part section is not realistic, as it appears that it limits people to confined spaces. The people move around. Therefore, the notion that a user must subscribe to one provider entirely may frustrate citizens, and it is tantamount to impede on the individual's rights to access healthcare and freedom of movement as residents, as prescribed in the Bill of Rights 20 in brackets 21 and 27 of the Constitution of the Republic of South Africa. So our proposal is that we propose a provision that addresses issues of mobility and easy transfer of patient, sharing of patient information by service providers. We further propose that the electronic health information system should be improved and working at the time of implementation so that health providers can easily access patients' records without patient having to struggle. Because in terms of the ideal clinic model, it should be easier for patients to access their information wherever they are. And that service provider or that institution should be able to access the information of that patient, because it might also provide a situation where the members themselves, the patients themselves, the citizens themselves might abuse the system if there is no clear system that identifies the patients correctly. So our rationale is that the system should be user-friendly and easy for both the user and the provider. Can we go to the next slide? Section 8 in brackets 2 of the bill, which is likely to open a can of worms and provide a window of opportunity for voluntary medical schemes to pay for services that will be offered by the National Service. This is likely to disintegrate further the ideal of having a single purchaser model of healthcare service, which the country has been longing for years. Our proposal in this respect is that we suggest heavily that this part be removed, as it may challenge the intended goals of the fund. I may not elaborate much on that because we propose that it be removed. Subsection 8, Section 8, subsection 2, in brackets series, that's 6. Those 6 services that are not deemed medically necessary by the Benefits Advisory Committee. Our proposal is that stipulate services that are not medically necessary. They should be stipulated. And the rationale.
This thing,
Hold on, please, Mr. Hold on.
please confirm what's on it.
Who is this rap?
Utamabot. One of someone is calling to start making a noise. Press.
Can the host please not mute me when you want to mute others, those who are hosting us? Thank you. Mr. Manamela, are you still there? Mr.
Yes,
Manamela?
I'm still there.
Yes, I want to speak to whoever is causing a disturbance on your presentation. I'm not certain whether that was from your side or somebody else. If they can please make certain honorable members and visitors to make certain that your people in your background, that you are muted and that there aren't disturbances caused to those who are presenting. Thank you.
Thank you. I was on section 8, subsection 2 in bracket C, which reads thus, 6 services that are not deemed medically necessary by the Benefits Advisory Committee. So what we're saying is that those services should be stipulated that are not medically necessary. Our rationale being that this will clear the ambiguity of what is not medically necessary, and people will be aware of those for curtailing complaints to the appeal tribunal. Can we go to the next slide? In this chapter, we note that the minister is responsible for establishment of the board, has the ability to dissolve the board, and appoints the CEO responsible for stewardship of the fund. And the fund must moreover account to the minister for the performance of his functions and the exercise of his powers, and the board must support the minister in fulfilling his or her obligations under Section 3 of the National Health Act. So our comment in this respect is that the huge contributor to the failures in the public health system at present is our view, is the blurring of lines between politicians and the administration. So in this respect, we propose that there is a need to establish structures or systems of governance that protect the fund from this risk. We didn't come up with what type of a structure, but we just proposed that maybe a structure, because the fund itself in the bill it stipulates that it is autonomous. So its autonomy might not be realized fully based on what we are raising in this chapter. Can we go to the next slide? Section 10 to 18 stipulates conditions under which the board shall be composed, powers and functions, remuneration and procedures. However, excluded dissolution of the board, in particular when it fails to deliver on its mandate as prescribed. So in this case, we propose a system that enables the board to be dissolved or fired, and those powers to be given to the minister responsible. The rationale to this is that if this is excluded in the Act, we may experience challenges in the future if we have to deal with matters that are mentioned above. And Section 13 in brackets 5, a board member is appointed for the term not exceeding 5 years, which is renewable only once, and must have appropriate technical expertise, skills and knowledge or experience in healthcare, service financing, health economics, public health planning, monitoring and evaluation, law, actuarial science, information technology, and so on. But our comment is that the skills listed excluded labor as part of the board. So we are of the view that the board should be inclusive and diverse and include all people of the society. And in this case, specific, we mentioning organized labor. Can we go to the next slide? Section 20 in brackets 2 in brackets E that reads establishment of an investigating unit within the National Office of the Fund for the purpose of investigating complaints of fraud, corruption, and criminality and criminal activity, unethical business practices, and abuse relating to any matter affecting the fund or users of the fund. We propose, in this light of the corruption and poor governance at public entities, there is a lack of detail with respect to how the fund will tackle elements of corruption. There should be a detailed process outlined in the regulation that will be operationalized in this act. Can you go to the next slide? The Benefits Advisory Committee, which is section 25 in brackets 2, the membership of the Benefits Advisory Committee appointed by the minister as well must consist of persons with technical expertise in medicine, public health, health economics, epidemiology, and the rights of patients, and one member must represent the minister. Our proposal is that we propose that the member of nursing fraternity and labor be included in the Benefits Advisory Committee, because our view is that plus minus 80% of the health workforce is comprising of the nursing who are with the patient 24 hours. So most of the things they will be familiar with, and I think they will give value to the Benefits Advisory Committee as much as they will need it. So our rationale, we need diversified committee as well as board expertise of all skills and knowledge to inform the benefits. Further, necessary huge workforce that take care of patients in private and public sector. Therefore, they have extreme knowledge and skills. The labor movement represents the majority of workers in the country who uses public service, and they have knowledge and skills required to advise, as I said previously. Can we go to the next slide? Section 57 in brackets 1 in brackets A proposes a two-phased implementation. From publishing the green paper in August of 2011 to the beginning of the first of the 3 phases in 2012, there was progress. That is public comments, setting human resource strategy, cabinet approval of National Health Amendment Bill, reclassification of health institutions, pilot district approval, inclusion in the budget vote, etc. But the second phase, as far as we are concerned, and in my opening statement, I was said, the period between 2017 and 2022, in our view, most of the deliverables that are there, it was actually mute. We didn't see much of the movement. And we proposing that all that was supposed to be covered during that period under review be fulfilled by the end of 2022, because we feel that there is a lot of backlog in that period of 2017 and 2022. So the rationale is that we are nowhere near strengthening the health systems to meet the minimum standards required as set out. Nursing cadre was realigned. It's just some of the examples that we are trying to give here to say nursing cadre was realigned, but lacks regulation and amendment of the Nursing Act, as well as the review of the nursing strategy, which expired in 2017. It is since to be reviewed where we are. In brackets 3, in brackets B, training of the workforce has since dropped, which is not in tandem with the primary healthcare engineering. Nurse production has dropped significantly, with 1 intake per annum. Several nursing colleges are closed, with those remaining not accredited to offer new qualifications. So if you look into the bill when it's talking about the contracting units, that is where it talks mostly about re-engineering of the primary healthcare, and that is where most of these cadres will be needed. So if the numbers have dropped that significantly, it will create a big problem for the implementation of the National Health Insurance. Can we go to the other slide? Thank you very much. That is all that we have prepared. As I said before, that most of the parts of the bill we are covered as an organization. So we just thought these are the few things that we'll give input on. Thank you very much.
Thank you very much, Mr. Manamela, and also to your president, Mr. Hlungwane. We appreciate you coming to do this presentation this morning. There are a number of honorable members who would want to raise questions with you, and I'm going to name them in order. It's Honorable Ismail, Gela Clark, Sukacha, Muniai, Chirwa, and Tembakwayo. So I'm going to repeat this. It's Ismail, Gela Clark, Sukacha, Muniai, Chirwa, Kwayo. Any other member would want to raise anything with the NOSA? You can shout your name on the platform.
Chair, if I may, I don't want to ask a question. I've just had a call from the Honourable Clerk. She was in her office.
We also cannot hear you, Honourable Wilson. Honourable Wilson. Honourable members, when we do come to Honourable Clerk, if she is not available, we will move on. So I'm going to repeat. Ismail Dela, Clerk, Sukacha, Munyai, Cherwa, Temba Kwayo. In that order, please. Thank you.
Good morning, and thank you for the thorough, presentation. I just have a few questions. My first question, in your opinion, has the department adequately planned for the NHI, taking into consideration that the pilot projects were not an effective tool for establishing where the NHI will work? My second question, do you really feel that we don't have universal healthcare already in South Africa? I mean, we have public healthcare facilities that are available to everyone who choose to use these facilities. Is the NHI not reinventing the wheel? My third question, do you feel that with the current shortage of healthcare workers, now we know that both community service doctors and nurses are having difficulty being placed by the department, due to budget constraints, etc., etc. And with the current infrastructure crisis, we know that most of our healthcare facilities are, really in dire straits. Will the NHI really work? Do you think we will have access quality healthcare if we don't ensure first that we increase the amount of healthcare workers in the system and improve our health infrastructure, etc., before the NHI is implemented? My fourth question, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our healthcare facilities, and the fact that, health facilities need to reach certain compliance requirements, under the NHI, a lot of these clinics will have to be shut down or closed. Now, this means that, many will close and thus access to healthcare will be limited. So do you really feel that the country is ready for the NHI? Also noting the fact that, the health ombudsman can't manage to oversee and ensure compliance. How are they actually going to manage to ensure compliance under the NHI? Now, my fifth question, we already know of at least around 104 billion rand in medical negligence claims. Won't this even be worse under the NHI? And sixth question, do you feel like the NHI bill in its current form will be providing a health value-based model? My last question, do you feel that the NHI meets constitutional requirements as it stands? Thank you, Chair.
Thank you very much, Chairperson. Let me first welcome the presentation from the presenter. Chairperson, I've got a few questions that I want to ask the NUSA. I hope I'm audible, Chair.
You are, Honourable Gela, you're welcome.
Yes, Chairperson, thank you very much. Firstly, let me appreciate the input from the NUSA, and also I'm happy that you are supporting the NHI, the implementation of the NHI, which I think it's a good move for South Africa, for us to be equal, because currently when you check the health system, it's in balance. So NHI is going to correct that. And also, as you also mentioned, the issue of idea clinics, we really appreciate. I think as a country, NHI, it's a good move so that all of us, we can be equally, we can be treated equally, no matter what kind of status you are. but NHI is going to address all those challenges that are faced by the health department so far. Coming to the questions that I want to ask, on section 1, that is dealing with the definitions, you have recommended that there is a need of a clear regulation of the private sector. Can you please elaborate more on that one? What are the key areas that need to be regulated? That will be my first question, Chairperson. Then my second question, Chairperson, the NOSA has a concern about section 2 of the bill, which makes a provision for voluntary medical insurance schemes and any other private insurance schemes to render services to persons that are not entitled to healthcare services purchased by the fund. Where do they suggest these individuals should access healthcare services, as it is not very clear in the presentation? Thank you very much, Chairperson.
Is Honorable Clerk able to speak now? If not, we will go to Honorable Sukacha. We will give Honorable Clerk another opportunity, or she can post questions to me or on the PC group, and I will raise it on our behalf. Honorable Sukacha.
Thank you very much, Chairperson. Let me also welcome the presentation from DINOSA, and good morning to all my colleagues. Chairperson, I've just got one clarity-seeking question from to DINOSA. DINOSA have also raised important issues about the interpretation of Section 7 2DI. The National Health Insurance Bill defines emergency medical services as follows. It states that services provided by any private or public entity dedicated, staffed and equipped to offer pre-hospital acute, let me just look at my papers, pre-hospital acute medical treatment and transport of the ill or injured. While Section 35(4)(a) states that emergency medical services will be provided by accredited and contracted public and private healthcare service providers when necessary. And do these sections not address the concerns that the NOSA have raised in their presentation? Thank you very much, Chairperson.
Good afternoon or morning, because we're at 10:57. I want to ask the person to DINOSA trade union. Is it the leaders of the trade union and the presenter worried that Section 7(2)(a) might lead to the denial of care for user? Are the leadership aware of the Section 6, which outline that those rights of the user, which state that, open quote, receive necessary quality healthcare services free at the point of care from an accredited healthcare provider or healthcare establishment upon proof of registration with the fund. We have been told that the health patient registration system will ensure that all users are registered to access healthcare within their catchment areas. And through these systems, access to healthcare services will be portable, meaning that we won't be out of area coverage issues. Are you familiar with the Section 40 of the bill? Does it address your concern? The other question, Honorable Chair, is that the presentation of the leadership of DINOSA highlights a problem with the minister's role, minister's appointment, the bill. Risk is cited as your main concern. Is DINOSA aware of provision of Section 18, 1921, and other sections in the bill, where provision is made for minister to consult with Minister of Finance, Portfolio Committee, and also get approval from the Cabinet before implementations of any recommendations? If these structures are not adequate to provide oversight in actions of the minister, then which other structures does DINOSA propose should be considered for inclusion in the bill in order to prevent the risk cited by the presenter? Does DINOSA want to change the democratic constitution so that to change the current constitutional role of the minister? If we can be clarified, Honorable Chair. And thank you for the presenter of DINOSA. Thank you.
Thank you very much, Chairperson, and thank you to the presenters for their presentation. I just have a few questions as well to DINOSA. Firstly, I want to ask how DINOSA responds to the issue of infrastructure that's not encapsulated in the NHI bill and what they then propose in relation to that. By infrastructure, I mean like the refurbishment, the renovation of hospitals and clinics. I think we saw in the past few days the issue in Gauteng of hospitals not meeting certain standards. So stuff like that, and that it is not people who are living in township areas and informal areas, in rural areas, will still be subjected to the current public health system as it currently is, and not have to rely or, to have the liberty of going to Medforum if they are staying in the CBD in Pretoria, when they are staying in Mandela, for instance, in the same city but in a different geographic place. Because also of the issue of the referral system that is also in the NHI bill. So again, that brings me back to the point I made above in the issue of the fact that people in rural areas and township areas and informal settlements will still be subjected to the current public health care system. Now, the fact that the NHI does not address the issue of infrastructure, I want to know what DINOSA says about that particular point, because all the funds, or majority of the funds, will be redirected into carrying the cost of the NHIF, and not necessarily dealing with the issues that are encapsulated in the public healthcare system. So I want to know your position on that particular point. And secondly, the issue of the security of healthcare workers. On most occasions when I go to do oversight in local clinics and hospitals, there's a very big complaint on the issue of security, to such an extent where healthcare workers get physically assaulted and abused by community members. I'm asking this particular question because I see you haven't said anything about that particular thing. And it's an issue that nurses complain the most about, because now the community that sees the incapacities of these healthcare facilities, lack of staff, lack of space and all of those things, they then put the blame on nurses, who then get violated on their way home or coming into the facilities. And even inside the facilities. Now, there's been many recommendations to the NTOH on how to ramp up security, but it has obviously fallen on deaf ears. And one of them is including or installing their biometric system in pharmacies and stuff like that. But all of those things have fallen on deaf ears. So I want to know what the NOSA says about the issue of security of nurses, because you have not touched on that particular issue. And it's something that they raise as well. So, sorry, just to digress a bit more, but going back to the point I made above on the issue of infrastructure, also during these oversight visits, your nurses will complain a lot about the fact that there's too much influx, especially in like regional and district hospitals. There's an influx of too many people, which then puts a strain on them, right? Which then makes also this particular question on infrastructure very relevant to your constituency. Because then the overburdening of work of people, like they'll complain about the fact that, for instance, Emmanuel Day Hospital, they'll tell you Kalinen, whatnot, this community and this community comes here. Kailicha District Hospital will tell you the same thing, that there's the community and the communities and the population in the surrounding areas are growing. Eden Vale Hospital is the same situation, where they cater for the suburbs and also township areas because of the issue of infrastructure, right? And now this burden is carried primarily by nurses. So also going back to that question, please also address that in that light. And secondly, I want to know your views on the retainment, the absorption, the training of community healthcare workers, them being on contract. Like, what's your whole idea on the issue of community healthcare workers in relation to the NHI bill, and how you envision their role going into the future within the NHI? Because you obviously stated that you support it. So I'm asking in relation to that position that you've stated in relation to this. And lastly, you spoke about the issue of documentation, but I didn't quite grasp what exactly you were saying when you mentioned the issue of illegal immigrants. So please just clarify that. But this time around, please keep in mind that the issue of documentation is not an issue that is isolated or in silos in relation to just illegal immigrants or immigrants, right? There are hundreds and thousands of South Africans who are flooding Home Affairs branches each and every day, who don't have documentation, which the system does not favor or is warped. People who were abandoned by their parents when they were born, people who were raised by their grandparents, but who didn't have the knowledge or the literacy to take the necessary steps, people who are homeless, homeless people who don't have documentation living in the streets. What exactly is your position on that issue of documentation, also considering those particular persons in relation to your presentation? Thank you very much, Chairperson.
Thank you, Chairperson. Thank you for the presentations, the DONOSA. My first question is based on the comment made on the complementary health benefits, benefit services. What I want to ask is, what are those services that, according to the NOSA, would not be included under complementary health benefit services? Because that is the comment that you made here. The second question is about how clear should clear regulations on implementation be, because you commented that the regulations on implementation are not clear. And the last one is 2-in-1, based on population coverage and registration as users. You leveled a critique on the way, the question was, it's not clear whether in NHI there is a reference to asylum seeker or illegal immigrants. But if you read section 4 clearly in brackets 1 and 2, there is a clear reference where they say an asylum seeker or illegal foreigner is entitled, and then you can continue with that. So my question is, what is it that is not clear here? Because the clear information is given here under section 4 in brackets 1 to 2. The same applies to the question that you asked on the registration as users, to say mechanisms for identifying the illegal foreigners. And whereas under Section 5, there is in actual fact clear information on registrations or users. So my question is, what is it in actual fact that is not clear here? Because Section 5, like I said, give appropriate information that is needed. Thank you, Chairperson.
Thank you very much, honorable members. Let me just remind you, and this does not have bearing on the latter speaker, that we should try to put our cameras on, because we do have live transmissions on YouTube, Twitter, and Facebook, and we will have delayed broadcasts with the parliamentary TV. And this program is also being published on IONO. And a number of the honorable members did not switch their cameras on while asking or raising their questions. Let me also take this opportunity to welcome our DM, previous chairperson of the subcommittee on health, or the committee on portfolio committee on health, Dr. Lomo, to this platform. You are very welcome to this morning's presentations, Dr. Lomo. Any other member? Honorable Clark, are you back? I have also looked on the platform that you have not forwarded any questions to me. Honorable Clark? If you are not back, I will raise my few points with the NOSA on their presentation. And it basically speaks to two things. The one is on your concerns on Section 8, subsection 2, and the other one is on your suggestions on the members of the Benefits Advisory Committee. Now, on the first one, with regards to Section 8, subsection 2, it seems that you suggest that the proposed role of medical schemes in the bill must be removed completely, since it would be used by medical schemes to provide funding for duplicative cover. Now, I want to remind you of sections 33 and sections 58, and also section 6, 6.0 and section 25. In section 33, it states that once the national health insurance has been fully implemented as determined by the minister through regulations in the Gazette, medical schemes may only offer complementary cover to services not reimbursable by the fund. And it is supported by section 6, as I mentioned, section 6.0 and section 25. With regards to the same point, whether you are familiar with section 58, which amongst other things propose amendment to the Medical Schemes Act. Question is whether that amendment, in your view, will not provide a legislative oversight on complementary cover to be funded by the schemes. And then what is your view about choice, since the sections in the bill dealing with medical schemes and other voluntary health insurance schemes seek to safeguard some level of choice in the funding for complementary cover. Then with regards to the benefits advisory committees and your suggestions, you're suggesting that a representative from the nursing fraternity must be appointed, and you're also suggesting that a member from the organized labor must be included in the benefits advisory committee. Now, this presentation seems to suggest a nurse is not likely to possess the skills and qualifications in health economics, public health, and epidemiology. I would like to hear what your view is on that, as the persons or the representatives to be appointed to the Benefits Advisory Committee is provided for under Section 25 of Chapter 7 of the book. So, most importantly, the question is the presenter suggesting that the representative of every health professional should be considered for appointment into the Benefits Advisory Committee? And if that is so, why should this be done? And on the section on the organized labor representatives, your suggestion that a representative has to be included, I would have to ask you, how will their inclusion contribute to the work done by this committee? Honorable members, we have come to the end of the questions to be raised by the honorable members to the presenters. You are very welcome, your president of the NOSA and your presenter, Mr. Manamela, to address these questions and concerns which were raised with you, and we're looking forward to your answers. Thank you.
Thank you very much, Honorable Chair and honorable members, for the questions that were raised. I must put a disclaimer to say, not having been favored with the questions upfront, all of them, and when they are raised verbally, now you have to jot down all of them. So they might be longish, and if we happen to miss any of them, maybe it might assist us if we are being advised to say this one has been left out. But I want to start, and not in any particular sequence, but just dealing with the questions. Some may be clubbed into groups, but fundamentally, our belief is that where the health system, in particular the public health system that we have, was designed to deal with a certain number of population that we have had in the past. And it is our belief that the current setup of the public health system is designed to deal with the health challenges of 1997. That then tells us that it is way and far behind and backdated. Because at that particular time, and I might give an example that at some point our country had a population of around 46 million. Currently, we're talking to around or close to around 60 million population. The health system has not been designed to move with the times. The disease burden at that particular time was very low. We never had a challenge of HIV. We never had a challenge of serious chronic illnesses that we have seen in the past 10 to 20 years. We had also not had a challenge of corona. So right now, the challenges or the health burden, the disease burden has become even more. But the system itself has been designed to deal with the old way of system. And as a country, we have not seen, in terms of the public health, improvement that one could say we are happy. This is why I would answer directly to say the pilot project for the NHI, where when you look at the survey that was done or the assessment that was done after 5 years, it tells and shows that we have performed dismally in the pilot project itself, which then says more needs to be done to address, if NHI is to be successful, to address all the challenges that would have been picked up by the survey itself after a summary. But it is our belief and firm belief that when we have seen challenges through the pilot project, it should not discourage us not to forge ahead and correct these areas that have been identified by the pilot project. Because we can only learn from the pilot project to know that we need to put more efforts into this particular area. That then drives me to then address the questions that I think are going to be clubbed together. The question raised about the Office of Health Standard Compliance, the question that was raised about the Ombudsman, the question that was raised about infrastructure, and at some point, the question raised about security. That speaks to systems developments. Systems developments that will include the planning, the management, and also in the planning processes must include the question of maintenance in place. And I'll give you an example that when Charlotte Maxeke main entrance had to collapse was due to the fact that there was poor maintenance or lack or no maintenance whatsoever. When the fire engulfed Charlotte Maxeke last year and continuously could not be contained was because the hospital was designed ages ago. Maintenance was never done at the appropriate level. As a result, it led to the dilapidation of the building. And I would personally remember that at some point, Department of Labor would have issued a certificate to say you must close this hospital. And the dilemma was between when you close, where do you save these people? So it then says when you have to plan this system, there must be serious commitment to be addressing systemic issues, but also maintenance issues at all. So it can provide us an opportunity as a country that this planning must be done properly. But planning for 46 million cannot work because we are talking about 60 million, and over and above that, we have undocumented people who were not captured in the statistics. I know of a person who have been struggling in around the area of Delmas, who is just a child above 20 years struggling to get an ID. The only thing this poor child could know is to be shown a grave of his mother and a grave of his father. But when he applies for an ID in Home Affairs, he gets told he must prove by providing certain documentation, which he cannot even provide, which means this is an undocumented South African citizen, but he is deprived of that opportunity. So for such a person, the systems that should be captured should be able to take into cognizance that not everything is homogeneous and there are challenges that are there. And we fully agree with the question of the standardization of access and ensuring that we have a better system. I can confirm that where I originally come from in Malamlel, if you have cancer, there are no diagnostic measures. And if you have cancer, you have to receive treatment. There is no nearby hospital to take care of you. If you have to find treatment, you'll be booked in Mankweng or Polokwane Provincial. Normally, the referral system there, you will be told the waiting period can be not less than 3 months. More people die while waiting to go and be seen by a specialist in Polokwane or Mankweng. More people die because sometimes they die at a time that the appointment then arrives, which then means access. When we say everybody has access on the argument that was raised by DA, it is a fallacy because if you say access, but you're only looking at urban areas, you are looking at people that are affluent, you do not have the touch of what is in the rural area. Where I come from, my own sisters, my own cousins don't have medical insurance. They cannot afford a private doctor. But when they go to a public hospital in Malamlelo Hospital, most of them get referred to Polokwane, and sometimes the referral system tells them that you're only going to be seen after 9 months. More have died of cancer while waiting to be treated for radiation or whatever treatment that must be provided. Now, when you bring NHI, you try and develop a system that will distribute services all over, but it would also provide and grant access to private sector. It means I will not have to rely on my income to get that access. That's why we firmly believe that an equilibrium should be created of some sort in this regard. We also believe that COVID-19 has taught us as a country that there can be collaboration between private and public sector. And we think if COVID legacy can come out to be the most functional NHI, we should learn from the COVID cooperation because the private sector, public sector, working together, ensuring that we secure treatment or vaccination, but assisting each other, we can learn from that particular process. But those are in power can be able to then begin to develop systems. So when we say systems, it means where there's gaps in the Office of Health Standard Compliance, resources must be pumped in to make sure that those gaps are addressed. Ombudsman as well, then we develop a system that is proper. Now, when it comes to security, we believe the system currently of tenderizing the security in the hospital, it doesn't work because the security that comes, some of them don't even have an idea of what a hospital or a healthcare setup should be like. They would not know, not in a way, a high pregnant person who might be in labor at a gate asking several questions as the person gives birth. They might not even know when, if you tell them you must turn away a person who doesn't have a referral, if you are coming to a level 3 hospital, they might strictly adhere to that. But we know as health professionals that before you turn somebody else, you must have assessed that this person will not complicate on the way before turning around. So we believe if people can be employed in the government sector itself, they can be trained properly. You can have control of them, unlike if you do not have that. And surely, as it is stated, we agree with what is raised by Honorable Chirwa, that security is a serious concern. Hence, you have seen evidence and the reports that there was rape in many other areas, stabbing and so on. And that's why we always keep on fighting that it should happen like that. And the shortage of health professionals, we are worried that as a country currently, there are nurses who would complete a 4-year degree or diploma, and even with the new system, it will come differently. When they are done, they are placed to do community service for a year, after which it's a 5-year investment. Then they are let go and not provided for employment. Yet, when we look at the population growth, the disease burden, when you look at international reports, including what the World Health Organization has released in 2020 on the state of World Health nursing report, it does say that each and every country must grow its health population, in particular nursing, by 8 to 10% annually, including the intake. If you were to look at the statistics of the intake of nurses in South Africa currently, you will realize that in the past, if I were to give an example in Gauteng, out of the intake of close to 900, currently the intake is below 300. It then says, as a country, we are regressing and not progressing. Yet, the World Health says in the year 2030, we're going to experience a shortage of around 20 million health professionals. In that regard, we are talking about international around 13 million of nurses. And in our country, it's even worse. We do not even have the standards that would develop to say, against this particular population, how many professionals of what category do we need as a country? We have a shortage. At the current moment, if you look at the number of people being trained for critical care, for primary health care and so on, you realize that we are just way behind what is then can be directly acceptable. So indeed, it is a concern, but we believe if we are, as a country, going to invest in the development of system, address the issue of infrastructure. The infrastructure we have is dilapidated, poorly maintained, and old-fashioned. If you go to the poorest of the poor hospitals, like one of the hospitals is Tembisa, it is designed during the apartheid. It was designed for the poor blacks, but currently it takes a high number of people. Even the newly built, your Begim Langeni and so on, you'll find that the bed approved these are the reports that we always get. The bed approved can be around 40, even this time of COVID. But when you look at the occupancy at a given go, you find that where you're approved to admit 40, you're admitting more than 70. That spells out a disaster that in case you want to do a resuscitation, you might run out of an oxygen point to resuscitate the other person. As a result, it then suggests that you could be, rather than a healing platform, but a killing platform, because you do not have adequate resources that can enable you. And in turn, it turns out to be health professionals that are being blamed that you are failing to provide this particular care, whereas it is a problem that is systemic. And we fully agree the challenges of negligence claims is because we don't even have a plan to deal with such. We just think when there's a claim, we'll just settle it or we defend it. Sometimes we defend, or we have seen government where government defends unnecessary things, where it could be simple to just say here, there was real fault. So you could even avoid paying legal costs in that regard. So it's only informed by the fact that there isn't any plan. So we believe that constitutionally, it is a requirement of everybody to get equal access. That's why we support NHI, which we call universal health coverage. The community service nurses that are being let go, these are the people that could be assisting in terms of the human resource that we have. Currently, there's even pharmacology graduates, those who have qualified, Bachelor of Pharmacy, they are awaiting placement. They are sitting and languishing in their homes. But for them to be fully fledged pharmacists, they need to get an opportunity to do internship. They did need to get an opportunity to do community service. Then they can even be utilized in the private sector and so on. We have systemic challenges that we believe should be addressed in conjunction with trying to realize NHI, and we believe that it is possible. And I must indicate that the challenge that we find and get report most of the time from our members is that you can go to the statistics around within the big hospitals in terms of the illegal immigrants. And I'm not being xenophobic, but when you look at the number of people that would be delivering at some point in some hospitals, you find that 80% of the people just come to South Africa to come and deliver because there's Chris and Baragwana that will let them deliver. And you look at the number of people who are South Africans become around 20. Now, it is created by these porous borders and many other issues, but if we do not have a well-functioning SADC, if we do not have a well-functioning country with systems that are working, the NHI in preparation should provide us an opportunity to address all the systemic issues until when we arrive and say NHI is functional, just like the National Health System in the UK, which is currently then functional. We know it is older, it has had its trying times, but we cannot then fold our arms and not support a noble gesture and a platform, an idea that will assist my poorest grandmother at home, my poorest cousins at home, who have nothing but only their hope to be provided by government to get access to healthcare. So those resources must be equally then distributed to that effect. Honorable Chair, I think these are the few that I could be able to cover, and will then allow that Mr. Manamela will then add on the other questions that have been raised. I did indicate that the challenges, when they come long and you don't have them written to you, it becomes difficult to follow all of them. But I could sense that some of them can be clubbed in that particular way. There are those specifics that you have indeed asked in terms of the presentation that we have made. Thank you very much, Honorable Chair. I would think Mr. Manamela will add on the questions that were raised. Thank you very much.
Thank you, Mr. Slungwani, President of the NOSA. You would realize you have spent quite a bit of time, although it was very interesting. It is quite interesting to listen to you address the questions which were raised. So just to remind Mr. Manamela, we will give you extra time, but if he can also just go speedily through his responses. Thank you.
Thank you very much. I think the President has covered a number of issues that were raised by honorable members, but let me just go straight to some of the things that I think were not covered. The last things I think that were raised by, if I'm not mistaken, you, Chair, was about the inclusion of organized labor and the nursing fraternity skills that are needed there. But we still feel as an organization that we don't need ambiguity in the committee themselves. We just need prior submission. And I don't think in any way we were suggesting in our presentation that we need the we are in no way suggesting that the constitution of the country should be amended. I just want to cover most of the things that we're suggesting, that maybe in our presentation we're suggesting that we need the amendment of the constitution itself. The issues of the complementary cover, still we're saying we need them to be clarified because we may speculate. What is this complementary cover that is been talked about in terms of, I think it's section 33 of the Act, and you referred me again to the amendment of the Act in terms of section 58. Yes, we may agree, but it's not clear. We will need them to be listed to say either those complementary mean cosmetic, or what does it mean? Because we're not really very clear, because it might create an opportunity that people might expand the list as and when they wish. So it must be clarified that what is the list that we're talking about. And in terms of the, all right, I think the issue of the illegal immigrants, I think was clarified. I think we are covered in there. We're just addressing the issue of, I think we were the issue of defining whether the two can't be interchangeably used. But I think it was clarified in terms of the sections that we were referred to. I think it's section 4, 1 to 2. I think we are covered. I think mostly maybe what we wanted to stress was the issue of undocumented foreign nationals, also to be looked into, because emergency yes, the registration of users. Yes, we understand the process of registration of users. You must produce that, you must produce that. But what about those who can't produce? And those who even can produce in terms of them being immigrants or illegal in the country, you provide emergency services or those services that will be deemed necessary. But we are also saying we must also look into those who are undocumented. Let me check if there is anything that, yeah, there was the earlier questions that were raised about whether the country was ready, and so why, as the organization, we are supporting the national health insurance. We don't believe as an organization that we'll have a time where we'll say the country is ready, because transformation about healthcare, the discussions is very, it dates back many, many years ago. So it just takes the will of the leadership to implement. So we think it's a good thing that the country has finally decided that it will put the timelines that will start from this date, and then this by this date it will be its full implementation. In that case, we'll think in the process the country will get ready come 2026. There was a question about whether the country is it not already implementing universal health coverage? No, it is not. It is not providing universal health coverage already. We may think, we may maybe talk about the services to the children, the services to the mother and child, and so on. But we're talking about the general public access to health, as the president was saying, that the grandmother who is there need to be cross-subsidized, that those who can cross-subsidize for solidarity of the country. So we feel it's not, it's not already provided. And it will not provide shortage, because already there is shortage of staff, there is shortage of nurses, over 30% shortages of nurses in the country already. So NHI is not going to make it any worse. And indeed, it will work. We believe that it will work, because if, as the country, we pledge solidarity to the country, we cross-subsidize each other, although we haven't reached a stage where, how is it going to be funded? But we believe the manner in which it's going to be funded, we are going to cross-subsidize each other, and it will benefit even the person who was not having access to the most basic care that he needs at the very deep rural areas, as the president has already said. And I think the president covered the issue of the clinics, whether they will close because they don't meet standards and so on and so on. I think the president covered that. Based on the time, I'm trying to run through where I think the president didn't cover, but I think, thanks, Chair, that is as far as I can go, where I think the president didn't cover. And he covered also the issue of the minister and the powers that the minister has. I think he covered that as well. Yeah, thanks very much.
Thank you very much for coming this morning, and thank you for clarifying all those concerns and questions of the honorable members. Both you and your president, Mr. Manamela, we appreciate it. In closing, maybe you have a closing remark before we move on from you to the next presenter, for the next presentation.
Honorable Chair, for us is to thank the opportunity that you provided. It is our dream that our children who may appear destitute, the downtrodden of the country, may one day realize universal health coverage in whatever format that may be. We think this is a noble gesture and the ideal that if it can be realized during our time, it can help the country as a whole. But remember, we said COVID-19 has shown us that the public and the private sector can work for a common good. There will be no need for the old aged in rural areas to die before they receive tertiary care or specialist care in the medical field. While we all know that in the medical aids is also a cross-subsidization, because the young and unill or less ill people, they subsidize the old who are in need of more healthcare. So the same system can be translated to be a nationwide system. Thank you very much, Honorable Chair and Honorable Members. We appreciate this opportunity. It is much appreciated. Thank you.
You're very welcome and thank you for coming. You are welcome to stay on for the rest of the presentations today. You're also very welcome to leave. Honorable members, we have now a presentation from the young nurses in Daba coming up. They are represented by two persons. The one is President Rich Sitrina and the General Secretary Lerato Mtunzi. You are welcome, whoever is leading you, to speak first, introduce the rest of your team, and to follow through with your presentation. Thank you.
Thank you so much, Dr. Kenneth Jacobs. Let's first thank the Portfolio Committee for having taken time to include our organization as well as to consider the inputs that we had submitted through the Portfolio Committee to be able to be looked at. Thank you, Chair. With me, I'm with the President of Young Nurses Indaba Trade Union, Rich Sitrina, and my name is Lerato Mtunzi, the General Secretary of the Trade Union.
Just switch on your camera also. So, yes, thank you very much. Since it's a live broadcast,
Not a problem, Doctor. I'm not sure if our presentation will be shared.
I've given you co-hosting rights so that you can share. Thank you.
All right, thank you very much. Chair, perhaps let me start by saying our submission that was sent through to the Portfolio Committee is below, and I'm going to move from slide to slide, just high level, starting with our page 3. I think there we were introducing our organization, and for those who are not aware who and what Young Nurses Indaba is, maybe that would be important. For just take 2 minutes and just say that Young Nurses Indaba Trade Union is a union that was registered with the Department of Labor in 2017. It has been in operation as a recognized trade union since then, and it organizes healthcare workers, particularly nurses, as the name suggests, by no far only focusing on nurses that are within the ranks of public and private sector, and also mainly our vision being to unify healthcare workers, nurses particularly, in the restoration of the image of their profession, and ensure that that is achieved through empowerment initiatives that we do have. That is the previous leadership of the organization, and when we submitted the presentation, or rather the submissions, we went at pains, Chair, to engage nurses that we are organizing and those who are following us on various platforms. And whilst taking active part in various committees and various task teams, as a trade union, we've taken our time to try and understand what would be the need of the healthcare workers and those they serve in making our contributions on the NHI. But I think what summarizes our talk is basically sitting in our last. You've managed to go, but I think I want to zoom you quickly to the last page, because it summarizes everything that you see in all the various chapters that we have then submitted. And obviously, in respect of time, we want to go straight to those. We've termed them conclusions, but basically is what Young Nurses Indaba is recommending. We have said as a statement, we are fully behind the NHI. But we need to have our concerns that we've put forward to also be looked at. We do believe that the country is ready there's no better time to start NHI, especially after the pandemic that we've just encountered. That emphasizes that we have to try by all means to include the haves and not haves, and not have a system that continues to discriminate while we are in a democratic dispensation. Our first point really speaks about that we are advocating for a one-tier system. The one-tier system that we are looking at is a tier system that is indeed a universal coverage. It does not begin to mimic what the current medical setup is, where you will find that there is bronze, silver, gold, or emerald, or different tiers of healthcare system, which still puts other lives being more prioritized by the healthcare system above the others. And I'm particularly picking on this because this is a general practice within the private sector, which obviously you would have to qualify for certain benefits based on how much you pay or on what tier of the medical cover you are in. The same is almost done in terms on who you are or who you know for you to be prioritized, which minister you can call or which MEC you can call and complain bitterly so that you get the healthcare system. So we are saying for us to even consider NHI or to really say we are rallying behind it 100% with no reservation, it has got to be a one-tier system. The second thing that we are putting forward is that the pool of funds that is going to be sourced from various sources, be it individuals, be it business, be it from tax and all other streams. That money, as we know, our healthcare system is really plagued with corruption. It's plagued with looting. It's plagued with maladministration and really mismanagement of the state funds. We complain. It's almost like a boring song where we begin to complain about three major things that our healthcare system needs as a boost, which is the staffing norms, which is the human resources, which is of course the staffing norms, material resources, as well as the infrastructure. But if we are to pull all this money into one pot, and this money is not guarded safely, there is no committee that is a watchdog over this. It's not enough what is put in the bill currently. We feel that we need to have an outside entity, an outside body that is explicitly stated in the bill that will be their role and their purpose will be to ensure that funds that are collected in the NHI are really put to good use, and accountability is there from time to time. The third bullet that we are emphasizing on is the fact that we do not want a NHI that is disguised as a privatization of the healthcare system. We are saying it must be the responsibility of public health. It cannot be dual. There is no space where we stand, where we must still be tiptoeing around private sector and trying to find a space where we are saying NHI can coexist with private practice, because that would not actually be resolving the dire need of making ugogo senxuthu, nor even the granny who is in Sandton to get equal and a quality healthcare. And the commitment won't be as vigor and as strong as we would like it to be. We are also putting forward that we want that the NHI must not be ambiguous. It must be bold, and it must be clear in its pathways in terms of making sure that healthcare is not just primary healthcare. It's primary, it's comprehensive, and it cuts across all margins. And there's an intentional way in which the NHI commits that the three biggest pains in health, which is infrastructure, human resources, as well as material resources, are really intentionally targeted. That role is not displayed. It's not displayed to regionals or displayed to provincials. The national health insurance must be taking charge of the healthcare system that we find to really be in ICU at this present moment. we are also saying that we need involvement of young health professionals, particularly nurses. We feel that the bill currently is mentioning everybody else, but it's not explicit. And I think the latter speaker from DINOSA made a very made that point quite clear for us, and that for us is a sore thumb. We feel strongly that nurses should also be mentioned. We mustn't assume that when we say others, we mean nurses. If it's nurses, that must also take their rightful place in being able to provide or be service providers of the NHI in different forms that the NHI dictates. That must be very, very clear. We also feel that the new players, I mean, right now, if NHI were to go full bang and service providers were to be launched, the big hospital groups that are privatized currently, Netcare, Mediclinic, Life clinics, and so forth, Busamed, they would still have an urge over and above the small players. The bill is not clear as to how do we then begin to bring all this newcomers in the industry. How do we then capacitate those who need to be capacitated without necessarily saying it's NHI, but it ends up actually benefiting the capitalist, the monopoly capitalist. We also feel very strong around the issue of that. I've mentioned oversight. I've mentioned boards. That must really, for us, that is really a non-negotiable. And I think it's a point that we are upholding. And the inclusivity of women. Healthcare, whether you go through the statistics of the South African Nursing Council or you go through the statistics of the HPCSA, in the majority of healthcare providers is women. But at the helm of healthcare, we still find that we are not intentional. So we are saying the legacy of NHI will have to live, for the next 30 years if it were to be implemented tomorrow. But that must also focus on ensuring that in all these boards that I mentioned, in all these tiers that I mentioned, women are intentionally included to be able to be custodians in equal platform as their counterparts. We hear that the NHI, the bill, when you read it, it makes mention of CHWs, the community healthcare workers. It makes mention of EPWPs. It also makes mention of counselors. But those three categories, we know currently that the national department as well as the provincial departments of health are failing dismally in incorporating these categories that came as a need because of these shortages that we have of professionals. We have not formalized their training. We have not made sure that they are accredited in any way. And there's also a watch body, or there is a council that makes sure that the practice that they continue to offer in private sector and public sector is safe for our people. So we do feel that they must be regulated and the recognition must be fast-tracked. Obviously, if the NHI bill is already mentioning them, it is tiers that are in healthcare that we cannot get rid of because they need really deeply exist. We are saying equal access to comprehensive healthcare to all citizens must not just be a narrative. The current system, as we know it, continues not to bridge the gaps. Over the years that we are in democracy, we have actually not seen healthcare becoming better. We've actually seen healthcare declining day in and day out. In fact, if you were to compare the previous regime, the apartheid era, and compare to the current democratic dispensation, with every healthcare worker, they will tell you that we are worse off. And I think NHI will be, or we believe as YNETU that NHI is really an answer that we want, but there must be correct checks and balances. The majority of our Black people, mostly of indigenous groups, we cannot continue to ignore that their deep-rooted cultural and traditional beliefs needs to form part of our healthcare. It is extremely frustrating that this topic, it's done at surface value. It's almost as if we are accommodating or we are tolerating culture and traditions which actually makes or break what our healthcare system is trying to do. I think in the NHI must be clear that we cannot only want to westernize our healthcare system when we have majority of our people being indigenous, and this must be included, and in traditional healers must come out very strong without just made mention of in the NHI. And I think that's basically the long and short of it. I'm going to give to maybe our president, Comrade Sitrina, to maybe add where perhaps I have left off or could not articulate adequately.
Thank you, comrades. Nopala, you actually have said mouthful, and you've touched everything that we have discussed and that we believe as young nurses in Indaba needs to be addressed by the NSI. But what we need to emphasize and reiterate on is that at the moment, our healthcare system is we have a two-tier healthcare system in South Africa. There's a part that caters for those who are poor, and also there is a part that caters for those who are rich, of which we want to put that forward to say this NSI should actually address that particular gap. We can't have a situation where there are people in private sector and also there are those in public sector. It's either the end users or those who are or healthcare providers. We are in the public sector. We are always complaining about gross shortage of staff. These things are just like straightforward stuff, things that we were not actually supposed to be complaining about. If the NSI is not going to address the gross shortage of staff that the country is facing at the moment, the gross shortage of material resources, then we might as well put a stop on it and find another way. But as young nurses in Indaba, what we are trying to push is to say this NSI must address that particular gap. At the moment, we have a situation where we are still complaining about gross shortage of staff and gross shortage of material resources, but we are having professional nurses who are being kicked into the street by the same government, by the same people in positions of authority. We want NSI, we would like NSI to address that particular issue. In as far as training is concerned, comrade, as like comrade Liratom Tuz, our Nopala Chigelele has put it, to say we have we have CSWs, we have EPWPs who are actually frustrated out there. Even those who are on PESA at the moment as we speak, they are actually not getting the full benefits that every let's say government employee is getting. There's still a gap. There's still a long way or a mammoth task that we still as a country need to embark on. Hopefully, NSI will actually address that. But at the moment, we wish the private sector and also the public sector. Our belief is that if within NSI, we will still be having a private and the people within NSI who are prioritized, who will get a preference in terms of healthcare services, then that particular NSI will be nothing but similar to what we are having at the moment as the country. All we want to put out there is to say the NSI must not be a ground for looters. It must never be a ground for those who are selfish. It must never be a ground for those who strive on substandard so that they can actually widen their pockets. It must never be, whatever has happened with the pandemic, COVID-19, funds looted left, right, and center while people were dying on the ground, while healthcare professionals, nurses, and doctors were complaining about being burnt out, but people were actually aligning their pockets, those in positions of authority, politicians in particular. NSI should never take that particular direction. We don't want to see as young nurses in the trade union, 20 years after the implementation of NSI, we are now having a commission of inquiry into NSI looting scandal. we do not want to find ourselves into that in that particular quagmire. Thank you very much.
Thank you very much for coming to present this morning. We appreciate your presentation. Honorable members, I see only 2 hands raised. That is of Honorable Sukacha and Ismail. Please indicate on this platform if you want to ask any questions or raise any questions for the presenters. Third one is Honorable Howard. Anyone else? Munyai. So Sukacha, Ismail, Howard, Munyai, in that order. You're very welcome, honorable members.
Thank you very much, Honorable Chairperson. Let me take this opportunity and thank the Young Nurses in Daba Trade Union for their presentation. Just 2 questions from my side, Chairperson. The Young Nurses in Daba Trade Union, we have noted your concern about the definition of emergency medical services. We have acknowledged that, and we are acknowledging it. Just to check, do you know that the bill defines emergency medical services as follows? The bill says it is services provided by any private or public entity dedicated, staffed, and equipped to offer pre-hospital acute medical treatment and transport of the ill or injured. Now, if this definition is not sufficient, can it not be defined further by the Benefits Advisory Committee as outlined in the bill? Or can it not be defined in the regulation? Then my second question, on section 6.0, you have recommended that on health service benefits, anything that is deemed to be cosmetic must be subjected to special authorization. Are you aware of section 25, which talks about the Benefits Advisory Committee, which will be tasked with determining the National Health Insurance service benefits? Thank you very much, Chairperson.
Good afternoon, and thank you for the presentation. It was very thorough. I just have a few questions, and they are: number 1, in your opinion, has the department adequately planned for the NHI? Now, I ask this in conjunction with the fact that, taking into consideration that the pilot projects were not an effective measuring tool for establishing whether NHI will work. This means that, the pilot projects were actually not effective, and as a country, the money spent on the pilot projects were actually wasted. If I could say, it was wasteful expenditure. And we do not actually have pilot projects that are actually telling us whether the NHI will work in this country. So do you think the NHI will actually work? My second question, we know that the NHI is a funding model. Do you feel that as the NHI is actually a funding model, will the NHI in its current form be providing a health value-based, efficiency of healthcare to our citizens? My third question, we know that, we have a major issue with the placement of nurses and doctors. I think I'm inundated with calls every day from community service nurses and doctors who say, please assist, we need to be placed, and we're waiting at home 6 months, a year, and we, desperate for jobs. Now, this is happening right now. Under the NHI, is this going to be more effective? I mean, how do you think this is going to be more effective? Don't you think that we should actually be fixing the healthcare system now before we even jump to the NHI, so that we can ensure that, we have effective service delivery of health to the country, rather than jumping to the NHI and then trying to fix it? So basically my question is, how is the NHI going to work if presently already we have a shortage of nurses and doctors, and we know the bad state of our hospitals? I mean, I just received a call this morning where a pregnant woman was rushed to Boksburg Hospital, or a Tambo Hospital. They didn't get any joy there. They went to another hospital. They fought to get the patient into the hospital, and they basically the lady calling me told me she was basically in tears because she was not getting any joy or any assistance from the hospital. And the lady actually gave, the pregnant woman actually gave birth at 5 this morning, and they were only notified like this, the time that she called me, and that was obviously past 8 this morning. And she said the state of the facility was actually pathetic. Now, considering that the health ombudsman cannot even manage to monitor even 20% of our healthcare facilities, we know under the NHI bill there's certain compliance requirements for healthcare facilities to actually fit under the NHI. How is this going to work? Are we not going to be sitting as a country where 80% or 90% of our healthcare facilities will have to be shut down? Is this then not going to hamper service delivery to our citizens? Is this then not going to hamper the availability of healthcare services to our citizens? That is why I'm asking you, do you feel the NHI is actually going to work, considering we have so many issues? Don't you suggest we first fix these issues so that when the NHI is actually implemented, there'll be a smooth sailing, and we do not hamper or effective service delivery to our country? My fourth question, corruption was highlighted in your presentation. Now, do you feel that the single purchaser, single buyer model is going to, be effective? Or will this cause, a monopoly, thus increasing prices of medicines and possibly more openings for looting and corruption? What would you recommend going forward into the bill to eliminate this? My fourth question, we already know of at least, 104 billion rand in medical negligence claims. You will note I always highlight this. Now, won't this be even worse under the NHI, considering the amount of, negligence claims we're getting right now? How is the NHI actually going to cope without the private sector, as a sideline or parallel running in this country? Just a few more questions. Under the bill's current governance and organizational structure, you've stated already the risk of corruption. Now, what do you feel or recommend should be included to strengthen the accountability measures in this bill? My last question, or my last clarity-seeking question is, you mentioned COVID and how the country dealt with it. And I think, definitely it was, something worth talking about. But, we have to note and we have to acknowledge that the private sector really played a huge part in this COVID struggle, if I can call it that way. Don't you think that it actually highlights or, enlightens the fact that the private sector is really, really important in providing healthcare or effective and professional healthcare to the country, considering the basically inefficient healthcare system that we have right now? Do you really think the NHI will work without the private sector being there? Thank you, Chair.
Thank you, Honorable Chair. Good morning, everyone. Thanks for the presentation. I only have one question. The presenter has made an assertion that the bill seeks to deliberately exclude women from participating in South Africa health system and NHI. Can the presenter clarify which sections of the bill contain such information, and or on what basis is the young nurses in DABA of the view that NHI will exclude young women? Thank you.
Thank you, Honorable Chair. We have noted the presentation by young nurses in Daba. My first question, therefore, Honorable Chair, is as follows. According to the young nurses in Daba presentation, it appears that the young nurses in Daba believes that some provision of the NHI bill, particularly under Chapter 2 and Section 2 of the bill, seeks to further fragment our healthcare system, when in fact such provision, as catered in the section of the bill, seeks to provide users with avenues where they can access those services which cannot be covered under the National Health Insurance. Does the young nurses in Daba believe that costs associated with services that are not recently essential, such as forms of cosmetic plastic surgeries, just to do our face good, should be without injuries, should be paid for by the NHI fund? Therefore, the additional question, Honorable Chair, on the concern about accountability of the funds that will be managed by the National Health Insurance Fund, what is your interpretation of the clauses 50 and 51 of the bill on the role of the Auditor General, a very constitutional body that is responsible to look at those matters? What is your view? What the role do you envisage Parliament playing in its oversight role to hold NHI funds accountable? Lastly, Honorable Chair, does the young nurses in Daba believe that we should continue with the two-tier systems, which I want to repeat? Does the young nurses in Daba believe that we should continue with two-tier systems, which almost the private sector medical aid receive 8% to GDP, equitable to or amounting to over 400 billion, yet the rest of the population don't have access to that kind of budget money in the public sectors? Don't the young nurses in Daba believe that we need to have integrated system, which people, all the population need to be served, regardless of their socioeconomic status? If I can be clarified, please. Thank you.
Thank you very much, honorable members. Any other member before I raise my questions with the presenters? If not, thank you very much for your presentations. Once again, are you worried about Section 8, subsection 2 of the NHI, which will provide basic healthcare benefits? Just to remind you of Section 15(3)(b), which states that the board must advise the minister on any matter concerning the development of comprehensive healthcare services to be funded by the fund through the Benefits Advisory Committee. In the same token, I want to ask you whether you were aware of Section 39, subsection 8, which contends that the fund may withdraw or refuse to renew the accreditation of a healthcare service provider or health establishment if it is proven that the healthcare service provider or health establishment has failed or is unable to deliver the required comprehensive healthcare service benefits. And then you have also expressed a concern with regards to the medical schemes claiming from the NHI fund, and you contend that the medical scheme should not claim from the NHI fund and that their role must be made redundant or useless. So are you actually saying that you do not agree with Section 33, which states that once national health insurance has been fully implemented as determined by the minister through regulations in the Gazette, medical schemes may only offer complementary cover to services not reimbursable by the fund? And is it your view as a trade union, if this is your view as a trade union, what about those arguing for some level of choice which is permitted in the bill? And in the bill, and you've raised this very strongly, in the bill, the minister is allowed to play certain roles, such as the appointment of the board members. However, most, if not all of these or decisions must be taken or implemented after consultation with other structures, for example, the National Health Council, the board, and the Treasury. What, in your view, makes the minister, what makes you view the minister as owning the NHI fund? I note you're saying minister is equal to the NHI fund. And I'd like for you to maybe clarify this point. And what other structures would you like the minister to consult with for his or her role, which is not regarding will then not be regarded as monopolizing the NHI fund? Those are the questions which are raised to you. You're very welcome to answer those. Thank you, honorable members.
Thank you very much, Chair. We'll try and go through question by question. We hope we're not going to miss anything. The first questions received from Ismail were speaking on the issue of EMS, and I think it was just flowing from the presentation of Dinosa from what I could pick up. And the question or the dispute here is not even about the definition of EMS. The definition of EMS, which is the provision of emergency service to both public and private, is a straight and clear definition. I don't think anyone has any form of dispute here. What we are saying is the inclusivity of all health categories when we opt. If the bill mentions doctors or mentions other healthcare providers, it should then be able to do the same with the nursing profession. I think that's what we wanted to come out very strong, and that will then apply to EMS as well. The other question was really on the role of the Benefits Advisory Committee. I think this question came again on the last speaker and also from the chair, when they are saying the role of the advisory committee, which would be to advise the minister on changes that would be there in line with Section 33 and also Section 39 of the bill. We are very clear when it comes to this role. We've said even in our submission, the minister is given way too much power over the NHI, and I don't think there's anyone that is sitting in this tribunal currently that doesn't know that we as the healthcare system has been plagued with even ministers being, painted with a paintbrush when it comes to issues of looting and corruption. And I think for us, what is important is those checks and balances. And I think another question came out to say, which other committee should the minister consult, or which other oversight committee? We are simply saying what is put in the bill is inadequate. The advisory committee and their capability, their reporting, or they're advising the minister, there must be an external body. There must be an intentional external body that is not yet even mentioned in the bill that needs to be included for us to have that peace of mind that I do believe even Hasina mentioned around the issue of corruption and looting. One other thing that I think came out very common in the questions that we were given is the issue of saying, are we then saying that we do not agree with the fact that Section 8, or even Chapter 2, rather, let me start with Chapter 2, is telling us about the tier system. And are we saying that it's incorrect? Yes, we are saying that's incorrect because you are reinventing the wheel. You are doing exactly what the current system is, where people get or obtain healthcare based on their socio-economic status. And as a result, we are saying it should be a comprehensive system that covers everyone adequately. And when it comes to then complementary fund that the bill mentions in Section 33, as to whether should we be a medical aid's role will be to give complementary fund. We have said, and I think even the previous student have mentioned, it's not clear what is complementary funding, what is complementary services that they're making mention of. You have given us examples. I think it's our third speaker that said, are we saying the NHI must cover non-essentials, must cover cosmetic? No, we're not saying that. We are saying currently the system as it is, as it offers primary healthcare, it offers even up to tertiary healthcare, that should be maintained, and everyone must get quality, improved healthcare services. And we are saying yes, the non-essentials, the cosmetic things that are not life-threatening should not even be issues of debate here. And medical aids, if they are going to offer basic care, and I think, Chair, you are making mention of the choice. You only have a choice if you have. You only have a choice if you've got money. If you do not have money, you do not have a choice. And we are saying our healthcare system, these disparities are so vivid and they are so clear because there is that word that you're saying, the bill offers people choice. If we are giving everyone quality, prestige, or supreme healthcare services, we shouldn't even be worried about choosing. We can walk in any facility that is managed by the National Health Insurance, and we will be able to get quality healthcare by practitioners that are fully staffed with proper medical resources, with good infrastructure, and that would not even be a question of choice. It should be that we are giving that, and it's a right. It's not even a choice. It's a right to every citizen of the country. I think Hassim Ismail also asked that, are we saying that the country is ready, and we think if NHI comes now? We've said yes, we support NHI. We don't support the bill in its current form, but we know that there's not going to be a day in South Africa where we sit back and say, let's fix the public healthcare. Who must fix the public healthcare? The very healthcare, we are saying this healthcare system is in ICU. It's not even in ICU. We've even upgraded it. It's in mortuary. So are we saying the people that are currently consumers of public healthcare must sit there, wait for it for 100 years for it to be fixed so that they can pick up and match up and be able to then get healthcare service with their counterparts who can afford, who have a choice of where they must go? I don't think that is the rationale. I think the NHI is there to bridge exactly that gap. We are actually behind it. And even in its imperfections, we are saying this is something that we can start working on in making sure that the very infrastructure that must be fixed before NHI is implemented will be fixed within NHI. The staffing norms and even the failure of those calls that you're getting of people not being absorbed. The NHI to us is an administrator of healthcare. We are saying in healthcare as it is not working. Let NHI come in and administer healthcare and rewrite the books and not follow the norms that are currently there. It's basically making sure that we are talking about a clean bill of health, which we will be giving to the healthcare system. And that's basically our rationale for believing that this has got some form of way forward. Yes, there is a lot of negligent cases, but if we've got committees, adequate committees within the national framework that casts oversight on how province runs, how regionals run, how districts run, and there is clear accountability, it will even make the role of regulatory bodies, that is the South African Nursing Council and the HPSSA, work quite the load to be lighter. Because as you've said, currently we do not really have capacity. We don't have capacity to, even the minister doesn't have capacity to dictate to the MECs of health in provinces, because there is easily claim that, but we report to the premiers. And that on its own is another bottleneck within the healthcare system that makes us go nowhere. No one accounts to national. Everyone is doing as they please with the current form. Yes, we've made mention of COVID-19 in terms of should we then, don't we see the role of private sector? No, the only difference as a healthcare worker between private and someone that has worked for both private and government for substantial amount of years, I can tell you the role of private sector is at this present moment, if we are moving into NHI, we cannot be kissing or we cannot be tiptoeing around the fact that private sector plays an important role, except segregating and making sure that in those private facilities are people who cannot afford are actually denied healthcare, and we will hide behind medical aids, we will hide behind PMBs, we will hide behind a whole lot of things, but they will ultimately be, willed out into the very public sector that all of us have a responsibility to then fix. We do also believe that on the question of exclusion of women, we are not necessarily saying that the bill in its current form is excluding women. We are saying healthcare currently as we speak, it's not historic, it's the real, is the here and now where we are. Women, you can start from the national to provincial departments of health. Women are excluded in occupying positions of authority and ensuring that we move the healthcare system forward. Despite women being in the majority, and that is the point that we were making, to say NHI, when it steps in and comes in, must be able to bridge and work on those disparities that are clear and are so vivid within the healthcare system, despite women, again, I repeat, being in the majority of healthcare providers. There's also a question that speaks on the 8% which is providing for the elites. I'll say elites for a lack of better word. For us who are privileged, whether working class and above, who has got the right or who've got access to medical aids, we would all like to stay in medical aids, but we know that is not going to correct the system. Yes, we can say it's gradually, let's wean it off. But the reality of the matter is, if we as a country, if the NHI and the minister and the president of the country and everybody in the current state would commit to NHI, we would move somewhere. But if we are going to do it biggie and still, try and make everybody else who has money comfortable, then we are really not. We are really playing games. I think the last point that I wanted to make that probably also came out from the chair was the issue of the minister. And I want to reiterate, I know I've said this, and I think we do strongly feel that the bill is very generous to the minister, is affording one human in the country too much responsibility, and it's putting this advisory committees. And we know currently, even the regulatory bodies are advising in line with the Nursing Act, are advising the minister as to where the ministers who are put in those positions at that time listens is another story altogether. That is why our greatest advocacy on this is to say we from the minister, that does not marching orders from any of the boards that are created within the bill, and there is a thorough watchdog. We must emphasize that the ombudsman as well seems to not have any teeth. It's issues of sitting and recommending things that never get to be implemented in our healthcare system. I don't know, President, if I've left anything on the notes that you've maybe taken on your side, just to add on. I think I want to pause here. Thanks.
Thank you, Nopal. There are two things. There are two important questions that I would like to address, my leader, because there is a question from the leader from DA. I believe in everything that our comrade has said, the biggest question is, why don't we, even though you have touched that, no, Bala, but the biggest question is why don't we fix the current healthcare system before we jump into NHI? That particular question will be answered in line with the one that was saying, are we saying let's do away with the two-tier system? Obviously, because at the moment we have this private and public sector. In as far as us fixing the current public healthcare, like healthcare system first before we move into NSI. Remember, the two-tier system is actually reminding some of us to say you are poor, you are rich. It reminds us of our poverty. It reminds us of colonialism. It reminds us of apartheid. It reminds us of slavery. It just reminds us of the majority of this country, Black people in particular, that we own nothing in this country. We have absolutely nothing. The only freedom we have, there's no economic freedom. The only freedom we have is freedom of speech. That is why we are in this platform today. So why the public healthcare system in particular is in tatters? It's no longer in ICU, like Nopala has put it. It's in mortuary. Why? It is because those in positions of authority have money, have means to say when they are sick, they are not going to go to a public clinic there to be in a queue from 8 o'clock until 4 o'clock. When they are sick, they are not going to go to a public hospital, Liratong Hospital, Bara, Telle Mukwerane, for example, or Prince Mshieni. They are not going to go and wait for 8 hours before they are attended by the doctor. So as a result, that creates a huge gap in as far as saying why people don't care about the public health system that is in tatters. It is because those who are rich, those who have money, those who have means to say when they are sick, what it is that they are going to do. They just don't care because they are not the beneficiaries of the neglected public healthcare system. So in our position is to say, let's have one tier system. Let's do away with private or public. Let's have one tier system that is going to force all of us, the citizens of this country, to stand up and be all up in arms when things go wrong. Because we will be knowing that we are the beneficiaries of this healthcare system. Now, at the moment, those who are poor are suffering because the public healthcare system is neglected. The public healthcare system is neglected because its beneficiaries are those who are poor. And when you are poor in this country, your voice, no one will ever listen to your voice. That is why there are so many bodies and regulatory bodies who are advising our minister, but still, currently, as we speak, our public healthcare system is falling apart. We are complaining about gross shortage of staff now. We are complaining about ComServes, communities, professional nurses who have just completed their community service period, who are being shown that door by the same people who know, they actually know what we are facing in our public healthcare system. So if we have one tier system, that will make all of us to complain because whether you have millions in your bank, whether you are rich or not rich, whether you're a politician or not a politician, when you are sick, you must go to Bara too. When you are sick, you must go to Replay Hospital too. When you are sick, you must go to Prince Mshieni as well. When you are sick, you must go to Liratong Hospital as well. Not that you are going to go to Mediclinic in Santi. No, let all of us be subjected to one tier system so that when things go wrong, when the looting is happening, we'll be able to stand up and say, no, man, let's actually fight for this and fix. Now we are not fixing it because it's those who are affected are the poor. Let's not fix the public healthcare system first. Let's jump into NSI. The NSI will correct all the wrongs because all of us will be up in arms trying to fix the healthcare system. Thank you.
Thank you very much, both of you. Yes, Honorable Ismail, I see your hand raised.
Thank you, Chair. I just wanted to highlight to the presenter that please, when responding, can they not refer to politics? Because, you know, as members on this portfolio, we are actually asking questions as members of this portfolio and not necessarily as, you know, party liaisons. So please, if that could be, you know, highlighted. However, I just want to, you know, basically agree with the speaker that just spoke now to say, I totally agree that, you know, all of us are equals. And as such, you know, we do have our presidents previously and deputy presidents right now that actually go out of the country for, you know, to get effective healthcare. And, you know, that it just shows you that they do not have enough or sufficient, you know, assurance that the South African healthcare systems will actually provide effective healthcare to them. So I totally agree with you, Sam. But my questions was aligned to the NHI bill and whether we are going to be having an effective healthcare that's provided to the country because the NHI is a funding model. Thank you, Chair.
Thank you, Honorable Ismail, and thank you to both of you who came to present. I note your point that is raised, Honorable Ismail, and I need to also then remind those presenters about the point that you had raised so that we are mindful of how we respond to questions which are raised from the members of the Portfolio Committee. We thank you very much again. I'm going to allow you an opportunity, one of the two of you, to give a final word as you close your presentation so that we can move on. We are already 4 minutes behind schedule, so 30 seconds. Thank you.
Thank you so much, Chair. Let's just thank the Portfolio Committee for the platform. We have nothing additional to add, just to hope that during our lifetime, we will get to really realize the dream of having an equal and quality healthcare system that all our young healthcare providers eagerly await to serve their country with greatest diligence. Thank you, Chair.
Thank you very much. Just a correction, we are actually ahead of schedule, but Ms. Lamba, do we have the next presenters here, which would be Genetic Alliance SA? I believe they were to be led by Dr. Malherbe, but I do not see him on the platform. Can you please advise
Yes,
us?
yes, I am online.
Yes,
Thank you very much. Oh, so it's Kelly du Plessis. Thank you. If Honorable Ismail can just lower a hand again, so that, yeah, I'm not fooled by a hand that is a legacy hand. You are very welcome, Ms. Kelly du Plessis or Dr. Kelly du Plessis, in representing Genetic Alliance of South Africa. We welcome you to this meeting, which is a public hearings on the NHI bill. If you can please introduce your team and then go straight on to your presentations.
Thank you very much, Dr. Jacobs, and good afternoon to all the honourable members of the Portfolio Committee, and thank you for this opportunity to bring to the table the issues that we've raised in response to the NHI bill. So my name is Dr. Helen Malherbe, and I'm the former chair of Genetic Alliance South Africa, a non-profit organisation that we actually, and I just need to update you on our status, we actually did integrate into another NPO in March 2020, but obviously our comments are relating to the same patient constituency that we are representing in our capacity within the new NPO. So, and obviously our comments were submitted from as Genetic Alliance South Africa, because that was obviously prior to our integration in 2020. So I am now, I was the chair of Genetic Alliance South Africa, and I'm heading up research at Rare Diseases South Africa. And I'd like to introduce you to my colleague, Mrs. Kelly du Plessis, who is the CEO and founder of Rare Diseases South Africa, which is the NPO with which we integrated. So good afternoon to everybody. And without further ado, may I share my PowerPoint presentation?
You are welcome to continue. Thank you.
Thank you, Dr. Jacobs. Okay. Sorry, the Zoom things get in the way a little bit. So we just, yeah. So I've tried to make this as simplistic as possible, and I'm going to be raising 7 issues with you as outlined on this summary page, starting off with definitions. I thought just to ensure that we're all on the same page in terms of what we're talking about. We are talking about congenital disorders here. They're also known as birth defects, which is a synonym meaning the same thing. So they are defined by the WHO and the March of Dimes as abnormalities in structure or function present at birth, whether obvious, manifesting at birth or later in life. It may be caused by genetics or partially genetics, environmental issues, and many of them, the causes are unknown, but the majority have a genetic component, i.e. over 80%. How do rare diseases fit in? Well, rare diseases are essentially, most of them are congenital disorders, but they occur at a very low prevalence rate. For example, less than 1 in 2,000 of the population. This is the definition of rare diseases is currently being addressed internationally by the World Health Organization and Rare Diseases International. And we have also taken up the challenge here in South Africa to come up with our own definition, because we had not our own definition, but look at the literature. What is the best practice approach for actually the definition that we should implement here in South Africa? And so we are ensuring that we're in unity with the international, the global community. So rare diseases can include inherited genetic and acquired conditions, but again, very few rare diseases are acquired. The majority are genetic. And although you have over 7,000 or 8,000 rare diseases that have been described or characterized to date globally, and there's more being discovered every day, they are collectively common. So this cannot be underestimated, congenital disorders and rare diseases as a healthcare issue that's facing our population here in South Africa. What's also important just to contextualize within these definitions is that most congenital disorders and rare diseases are non-communicable diseases. So obviously in South Africa, as we're transitioning epidemiologically from having a large proportion of our mortality, especially child mortality and morbidity, being due to infectious diseases and communicable diseases, the NCDs are now coming in. And we're seeing that across all our strategies and our focus in government. And congenital disorders and rare diseases, because they are congenital, which means present at birth, they are very often the very first NCD that's experienced in life, and they need to be contextualized and classified as such within the NHI. Many of the diseases of lifestyle that we talk about in lots of the NCD strategies and so on are actually multifactorial CDs, which means there's a genetic predisposition. Think about in terms of, for example, cancers that run in the family, familial cancers, and so on. And there's a very large proportion of our population that requires genetic services, and genetics needs to be integrated into health promotion and disease prevention. With regards, and moving on now to the definitions in the actual NHI draft bill, one of the terms that was noticeably absent was people living with disability. Now, a lot of people, when we think perhaps of somebody living with disability, we might think of somebody who has visual impairment or has some kind of device to assist them with walking or so on. But many of these disabilities are from birth. So it's congenital disability, and that is often very much not taken into account. And I think it's going to be very important that we, at a minimum, that we include and define people living with disability and disability, I apologize for the typo there, into the document. There were a number of other terms in the definitions list that were quite ambiguous. I'm not going to read through all of them, but those that have been highlighted and bullet pointed on this slide and also included in our submission are those terms that we really feel need to be defined in the context of the document, because some of these definitions are too vague and they need to be pinned down. So because you have to make sure we're all on the same page first before we can go forward. So that's going to be very important because people have a different understanding of different terms. Okay, moving on to access to healthcare. Many congenital disorders and rare diseases are complex conditions, and they involve a large number of body systems that require care from a variety of different medical specialists and allied healthcare professionals. So they're multifactorial conditions and so on. And it's not very as simple as saying, I've got an issue with my nose, I need to go and see an ear, nose, throat specialist. It's a lot of the time it's affecting a large number of systems. Currently, the NHI doesn't provide effectively to uphold the constitutional rights of those with these conditions. In the Constitution, it says that must be reasonable, justifiable, and open democratic society based on human dignity, equality, and freedom, and take into account all relevant factors. We believe that currently, in the current form, the bill limits the right to access healthcare by those affected by these conditions. Specifically, in Section 10, it talks to adhering to referral pathways determined by a health establishment to have their condition funded. This is not always an option by a patient with a rare condition or a congenital disorder. Also in Section 10, in many cases, there is no cost-effective intervention for many conditions. In many cases, there is no treatment or no alternative treatment in place. And so we have to focus on novel or expensive and often off-label use in order to actually ensure that care can be provided. Now, the bill excludes conditions without a cost-effective solution in favor of those where there's more affordable interventions. For example, enzyme replacement therapy that's required for a number of metabolic conditions where a person may be missing a gene to make a specific enzyme to break down something in the body. For example, breaking down glucose to access energy in the body. So they can receive a treatment via an infusion every 2 weeks to a month, depending, to actually replace the enzyme that's missing so they can live a healthy, normal life. And I think we also need to think about not just the costs here, but also we need to think about the impact on the quality of life and the contribution to society in terms of being able to work and contribute to the economy. Also in Section 10, it speaks to where a user may purchase healthcare services not reimbursed by the fund through private healthcare insurance. But there's a bit of a conflict here because the MSA amendment bill states that the registrar may restrict the extent of benefits offered by a medical scheme. And so it's a bit of a, it's certainly not a win-win, but there's a bit of conflict there because we need to make sure that our patients are going to be able to access the healthcare that they need. Sorry, okay. Then the last slide relating to, sorry, going on to, have I missed a slide? Sorry. No, I've gone. Apologies. No, okay. Moving on to fund income and coverage, Section 3. It speaks to the fund, the NHI fund, being the single public purchaser and financier of the health services in the country. But there's no details or reference to the mechanism by which the fund will be financed, and this needs to be clarified and detailed. And we believe that a provisional funding framework should have been in place prior to the bill being drafted. In Section 4, to establish and maintain an efficient fund through the consolidation of revenue so as to protect users against financial risk. Now, families that are affected by congenital disorders and rare diseases already have an immense financial burden imposed of them. In many cases, it's a single salary household. A parent may have to forego employment so they can take care of their child. There's a significant loss of earnings. They're having to provide full-time care or pay for additional full-time care. And if they're required to pay from an NHI fund from their taxable earnings, in addition to having to pay for private medical coverage because they need access to services that aren't provided by NHI, it's going to place them at even further financial risk. And we've got this very vulnerable group paying for a mandatory service that doesn't provide for their needs, and then they have to pay those additional costs on top. So we're going to basically isolate and marginalize this community even further and put them at even more financial risk. We also have an issue with the financing of the NHI fund via a tax levy. There's sustainable issues there because we have such a small proportion of the population that are paying most of the taxes in South Africa. We've got a very narrow tax-paying base, and we don't foresee that being sustainable going forward. Moving on to point 4, in section 5 of the bill, it provides for the fund to design healthcare services as advised by the relevant committee of the board, which will be purchased by the fund on behalf of users. We would like to request that there be details on how this decision-making is done and how the decision is around which conditions are included. What about services provided, purchased to cover the treatment of less common conditions like rare diseases and congenital disorders? And based on previously published NHI benefits framework, there's no provision made for these conditions. What about the less common conditions? Those that are affected are required to contribute to the fund, but have no say in the purchase of services. The NHI claims to prioritize services to populations most in need, but this has to include congenital disorders and rare diseases populations and patients. And it's unclear from the draft bill if these patients will be covered at all by the fund. So while these patients' families are required to register, they may not have access to the treatment that they require. In point 5, we'd like to raise the issue of cost effectiveness relative to personal risk or cost and the overall socioeconomic impact. And we don't believe that this has been considered. For example, think about conservative treatment of scoliosis via physio and bracing, which amounts to physio costs and about 50,000 Rand per brace, versus spinal surgery, which is now closer to 300,000, that also has bracing requirements and physio costs afterwards. And surgery should be the last resort, but at the moment, and I'm assuming this is not going to change going into NHI, for the very severe cases, children are being operated early because they're in extreme pain and it's threatening their physiology, their breathing and so on. They're operated maybe at the age of 12, which stunts their growth. And it should only be the last resort when they have finished growing. There needs to be greater health technology assessments and looking at these things in more depth. Okay, the final slide relating to fund income and coverage. One of our concerns is that 85% of public hospitals and clinics could not be accredited to participate in an NHI system. Obviously, this may have changed since our original submission was made, but we need them to improve on this because they were unable to comply with basic healthcare norms and standards, e.g. maintaining proper hygiene, medicine availability, and this requires significant improvement, both operationally and financially. And for South Africans to truly benefit from a universal healthcare coverage system, there is a need for stronger accountability for wrongdoing and accountability amongst political and civil servants involved in the operation of the fund. And we believe this needs to run from top to bottom and bottom to top. And the failure to do this will directly impact the entitled user or beneficiary's right to life and have access to health services. And furthermore, the state must take reasonable legislative and other measures within its available resources to achieve the progressive realization of each of these rights. Okay, moving on to continuation of care and referral pathways. In section 10 again, it says that a user must comply with the referral pathways determined by a health establishment, failing which the fund will not be liable to make payment of any service benefits. And this is not viable for congenital disorder and rare disease patients. The implementation phases of NHI propose but fails to deal with the practical issues of continuation of care by existing treating healthcare practitioners. So you have patients who are already diagnosed with a congenital disorder or rare disease prior to NHI implementation. They may already be receiving essential care or treatment under a specific subspecialist or a multidisciplinary team of specialists and allied healthcare professionals. And a delay in receiving continued life-saving care could prove fatal for them. So coming back to this issue of specialities and practitioners and expertise in treating a particular condition, and it can't just be due to geographical convenience. It's a luxury in South Africa, and we realize that there is a shortage in even GPs, medical officers, let alone the various specialities that we have. So I think there needs to be some flexibility here in terms of allowing a patient to access the relevant specialist so that they can receive appropriate care, even though this may not be as close by as the NHI would have liked. And adherence to referral pathways determined by health establishments. For example, a patient must first be assessed by a nurse or an other healthcare provider in a primary healthcare setting. Now, yes, That's appropriate for those that are affected by a less severe and common condition, for example, a cold. And we understand that we want to reduce the number of patients going direct to tertiary care. But for somebody with a congenital disorder that's already diagnosed, that's already on receiving treatment and relevant care, it's going to be a waste of resources. So we feel there needs to be flexibility here, and this standard referral cannot be applied to all. It needs to be on a case-by-case basis. Okay, and also following on from that, previous diagnoses and ongoing treatment must be taken into consideration to ensure the most effective, timeliest access and reimbursement for patients with rare diseases and congenital disorders. And in fact, if you look back at the Patients' Rights Charter, it provides for patients to have the right to choose a particular healthcare provider for services or a particular health facility, provided that such a choice may not be contrary to the ethical standards applicable to such healthcare providers, and not to be abandoned by a healthcare professional or a health facility which initially took responsibility. So we believe that the NHI needs to take this into account and ensure that these documents speak to one another. And finally, for this topic, in section 11, a fund user may only seek the services of a specialist without a referral in the case of an emergency. Delay in accessing the appropriate treatment for a rare disease or congenital disorder patient may have severe consequences, including fatalities. And we believe there needs to be more of a case-by-case system for these complex patients. So in those cases, they can go back to a specialist. So we essentially request the clarity on the definition of emergency services and a clear definition on the process by which patients and healthcare practitioners of rare and specialized conditions are integrated into NHI health services. Okay, moving on to the next topic, rights of fund users, the users or the patient that are using the healthcare services. First of all, the right to informed consent. So the right to informed consent, as it is in the Patients' Rights Charter, is on the individual patient. And it's to enable patients to uphold their rights and to exercise their responsibilities in hand with their rights, so that they can have access to their health record as outlined in PIA. Now, the PIA process we consider is very onerous for an individual. It's not very efficient, and it can take a lot of time by which a user or a beneficiary may require such information. And by linking this right to access health records via PIA, the bill actually puts an undue burden on the individual to exercise their rights and responsibilities. And this may well have an impact on their rights to be given full, accurate information about the illnesses, the diagnostic procedures, and so on, associated risks and costs, and their right to obtain a second opinion from a healthcare provider. I think putting all the focus and the responsibility on the patient is just, it's too much, and there needs to be a balance there. Rights relating to personal information with PIA, it defines personal information as information about an identifiable individual, and it lists a lot of sections there. We feel that in section 5, the bill is vague, it lacks legal validity and will not withstand constitutional challenge, as no law may limit any right entrenched in the Bill of Rights as defined in the Constitution. They need to be synchronized and basically in sync with each other. And currently it means the patient is entitled to the benefits they would ordinarily be entitled under MSA of 1998, and the fund should not seek to replace these. And there needs to be alignment between the proposed section of the bill and the MSA amendment bill. The rights, going on with some more rights, section point 3, patient and or civil society representation in the various fund processes and committees. Currently, in the format of the bill, in the draft bill, it excludes representation from health-related NGOs, civil society, consumers, and users of the health services. This is both in the Benefits Advisory Committee and the Health Benefits Pricing Committee, and also in the design of the healthcare services, benefits and goods, and healthcare referral networks. And it's assumed that this will include which conditions are included and covered by the benefits. So there's no representation there from the users of these services. And we believe that these groups must be represented in these fora. And if excluded, any decisions made by the committees require prior public consultation via a formal process. There needs to be, to ensure patient centricity, we really need to include patients in the process, whether it's via a community advisory board or similar type of platform. Accountability for access to healthcare. The draft bill states that the fund must, in consultation with the Minister of Health, purchase comprehensive health service benefits on behalf of the user. And the Constitution of South Africa also appoints the Minister of Health as a representative of the executive accountable for healthcare for our citizens. So we are concerned that there's a conflict of interest with this dual accountability, and it may result in the patient being caught between the fund and the minister and further complicate the complaints process currently defined in the bill in relation to the fund. The Constitution gives the right to complain about healthcare services and have such complaints investigated and receive a full response on investigation. Okay, moving on to the next topic of cost coverage. In section 12, the fund, it says in the bill that the fund will only pay for health services for a condition that are purchased on the user's behalf by the fund from certified accredited service providers at no cost. Many of our patients with congenital disorders and rare diseases have many body systems affected and are treated simultaneously by a range of specialists, a multidisciplinary team of specialists and healthcare professionals. Now, as outlined previously, over 80% of these conditions are genetic or partially genetic, and serious conditions are life-limiting or chronically debilitating, resulting in lifelong disability, whether visual, hearing, mobility, and so on. And it varies, the birth prevalence of these conditions varies from the more common disorders, such as, for example, Down syndrome, which affects 1 in 500 births in South Africa, to rare conditions which affect less than 1 in 2,000. But the principle is the same. So overall, and I'm just setting the scene here so that you can understand why we need to take this into account with the cost coverage of NHI. The contribution to the disease burden in South Africa is proportionately increasing as deaths from other conditions decreases. For example, improved management of HIV and other infectious diseases has improved, so less deaths are occurring from those. So the proportion from congenital disorders, rare diseases is increasing because it's like an iceberg coming out of the water, because it's largely remaining unseen because we don't have data on a lot of these conditions in South Africa. But this is emerging as a major health priority in South Africa. So this has resulted in the scale of this health issue being underestimated, and so the conditions remain unprioritized. It's like a negative feedback loop, and the services are neglected, and the patients remain undiagnosed and misdiagnosed, unable to access the relevant care, and this affects the mortality and morbidity. So until we really focus on these genetic services, we are not going to significantly further decrease child mortality in South Africa. So the areas of speciality are needed to treat these conditions. They may not be funded by the NHI fund, or they may be in locations which cannot be reasonably accessed by patients. And the challenge that we have is that in South Africa, we currently have, the number may have decreased from 12 to 11 practicing medical geneticists in the country. And currently they are only in 2 of the 9 provinces. We only have them in Gauteng and Western Cape. And we have 8 genetic counsellors in state in those same 2 provinces. So there are 7 provinces that are not covered by genetic services, and they have to be referred to other provinces. So our question is, how will this capacity in supporting genetic testing via the NHLS, which has a huge backlog, how is that going to be increased and expanded geographically to ensure that services can be provided countrywide and universally to all? We believe that these need to be taken into account in the current system bill. And then the issue of progressive realization. We believe, or according to the legislative framework in South Africa, children's rights are fundamental human rights, and their right to access healthcare cannot be subject to progressive realization. There is a paper that's been published in this regard back in 2016 by Malherbe et al. While it's stated that NHI will not provide everything for everyone, which we understand, there's a limited pot of money and you're having to prioritize. But to not provide health services for these children that are affected, and the majority of our patients are children, because these are present from birth and they are conditions that progress very speedily, and 1/3 of those don't make it to their 5th birthday. It's a violation of their fundamental human rights to actually not include these under the NHI bill. And then the final topic I just want to speak to, following on from those needs that I've highlighted, is capacity building. So we believe that those efforts as part of the NHI need to include medical genetics, which have declined as a result of those competing health priorities I've outlined previously. And I've mentioned the lack of capacity we have with only full genetic service in 2 provinces. And the issue that we have is we've got a continual freezing of posts. So those that are qualifying as genetic counselors and medical geneticists have nowhere to go. So we spend the money training them up, and then they emigrate or they move into the private sector, which is already full, so to speak. We believe that the nursing curricula need to be standardized and updated, including relevant genetics content, to take advantage of all these genetic discoveries that are happening. We need to take those discoveries from the lab to the bedside, from the bench to the bedside, especially in primary healthcare settings where genetics training is currently inadequate. There was an amazing network of 16 genetic nurses. And when we were hit by the HIV pandemic, they were basically reallocated to primary healthcare, and genetics had to take a back seat. We need to build up that capacity again so that everybody, regardless of whether they live in Limpopo and Mpumalanga, where they live in a hut or they live in a complex, that they can all access the same care and the same level of care, regardless of how rare the condition is. We also need specialized training to develop genetic nurses that really specialize in genetics, and genetic nurse counselors to supplement the shortfall of the specialist medical geneticists and genetic counselors. And this was recommended in the 2001 policy guidelines. And you may or may not be aware that there are new genetics guidelines that were published last year online, and they were endorsed and approved by Dr. Nicholas Crisp. For the comprehensive package of health service to be delivered, the mandatory training required it's required to increase capacity to ensure that the services can be implemented. We actually have great policies. 2001 policy was also great, and where we fall short is in implementation. So we've got the plan out there. Now we need to put a budget to it and implement it. And this has to be incorporated into NHI going forward with all the relevant structures within NHI. And it's important for governments, well, generally around the world, governments usually recognize the importance of developing genetic services when infant mortality reaches 30 to 40 deaths per 1,000. We are way past this in South Africa. We have got a lot of catching up to do. And with an infant mortality rate, I think this is an old number, it's a little bit lower now, of about 26 per 1,000 live births. We are way past that point. And the only way we're going to reduce those child deaths is to tackle genetic services head on. So in conclusion, honourable members, I would just like to outline that at Genetic Alliance South Africa and our membership that has been incorporated into rare diseases do not believe that the draft bill can be accepted in its current format. We ask that these comments are addressed and shortcomings are rectified through further consultation with the various stakeholders and groups. We believe that true universal health coverage is where citizens can access health services without incurring financial hardship. A system of protection which provides the equality of opportunity for people to enjoy at an attainable level of health. And such a healthcare service needs to be available to all registered users and include promotive, preventative, curative, and rehabilitative and palliative healthcare services, regardless of the socioeconomic status or health status of those persons, at no cost impact to the registered user. We know this is the ideal of NHI, but it needs to incorporate or include those with congenital disorders and rare diseases. And all South Africans that are affected by these conditions, which is around 4 million of our population, are entitled to access appropriate timely care, and efforts must be undertaken to ensure this vulnerable group are not excluded and left behind. In the words of the SDGs, we cannot leave them behind. Let's leave nobody behind. I thank you, honourable members, and I'm open for questions and discussion. Thank you.
Thank you very much, Dr. Malherbe and Ms. du Plessis. I must say that I take my hat off to both of you to work in this very difficult field. And I also personally appreciate you coming here to advocate for those who have genetic disorders or rare diseases. So yes, that's just me commending you for the work that you're doing. From what I hear, your presentation is all about. Honorable members, we have heard the presentation. I have a number of honorable members who would like to raise some questions with you. I'm just now not certain what to call you. I know that when you had made your submission, you were Genetic Alliance from SA, from what I hear from you. But I also now understand you have a new name or a new NPO, or you are merged into one NPO now called Rare Diseases South Africa.
That's correct.
All right. So the members would want to ask and raise questions with you, Honorable Albert, Sukacha, Munyai, Klengwa. Oh, sorry, I missed Clark, so I'm going to repeat. Albert, Sukacha, Munyai, Clark, Klengwa, and Ismail if she's able to connect. If Honorable Ismail can hear and she's not able to connect, she is very welcome to post her questions either on the PC group or directly to me, and I will raise those with the presenters. In that order, honorable members, thank you.
Thank you, Honorable Chair. Welcome, GASA, for your presentation. You have provided valuable inputs. Thank you for your participation. Just one question from my side. Your concern that the bill in its current form does not effectively provide for the constitutional rights of South Africans affected by a common or rare congenital disease is noted. Are you aware of Section 25 of the bill, which talks about the role of the Benefits Advisory Committee, which will include the membership of different persons with technical expertise, including representation of patients' rights? Thank you.
Thank you very much, Honorable Chairperson. Yes, just let me also welcome the presentation. Just one question from my side. You have argued that there is no reference to the mechanism by which the fund will be financed, and you have also requested a provisional funding framework. Are you aware of the funding framework that was proposed in the white paper? And secondly, have you read Section 49 of the bill that deals with the chief source of income for the fund? Thank you very much, Chairperson.
Thank you, Honorable Chair. Firstly, Honorable Chair, let me ask the following questions. It appears that indeed that the presenters are seeking clarity with regard to Section 33 as it relates to NHI service benefits and complementary cover by medical schemes. Are you aware of the Section 33 that talks about the complementary cover, which does not include the benefits covered by the NHI fund? Are you also aware of the definition provided in the bill of complementary cover, which is defined as follows, open quote, third-party payment for personal healthcare services benefits not reimbursed by the fund, including any top-up cover covered by the medical schemes registered in terms of Medical Schemes Act or any other voluntary private health insurance fund, close quote. Are you also not familiar with the Section 58 of the bill, which amongst other things propose amendment of the Medical Aid Scheme Act for alignment with the bill? Honorable Chair, the presenter continues to state the issue of economic hardships. Post-COVID-19, across the globe, including the most industrial countries, has been the hardest hit, and their hospital systems were overwhelmed, and the resources are not endless, are not limitless. So therefore, to suggest that, firstly, the country need to have the money to order to implement its policies. How other policies before has been implemented? What has been the source of funding? Isn't general tax has been over part of them? And of course, all the countries, the more they get exposed, to financial difficulties, high raise of the GDP to, percent to GDP. But it does not mean the country cannot implement progressive policies that's going to address the interests of all our people. Because the challenges of the two-tier system, I'm sure you're aware of them. Those that can't get cover, that can get assistance, it is based on what? They're excluded based on socio-economic condition. Yet the rest, yet the other private medical schemes, they're receiving 8% to GDP. And they're receiving over 400 billion, and they're covering only 12 to 16%. And yet the rest of the population don't enjoy those benefits. I'm sorry about that, but the key issue, do you support, for instance, do you support the two-tier system in the Republic? I want to get your sense in that, because we think it's important to clarify that point. Because even in the sense of hardship or war, government will continue to fund that war. If you have really read the history of the World War, First World War and the Second World War, even if they can, the Treasury continue to print the money to fund the war. In our situation, for all our population, please clarify if you are so content, with the two-tier system. Thank you.
Honorable Clark. Honorable Clark, are you still available?
Yes, thank you, Chairperson. I'm sorry about what happened earlier on. We had an alarm system go off in Parliament, and therefore we had to evacuate. And I had to get home to get back onto the system. So I do apologize for that. The following questions I would like to ask. And thank you, Doctor, for a really good presentation and very informative in terms of CD and RD patients. What I want to know from you is, do you think the NHI will be able to have enough healthcare professions within the system to deal with these kind of patients that suffer from rare diseases? Because, when I speak to many health professions in the profession, they are not very, very partial to the way the bill is structured in its form at the moment. Then, in terms of the medical claims that we deal with in state hospitals, do you think that bringing NHI into play, that these claims would then dissipate in a far greater way than what we're seeing at the moment, because billions and billions of rands are being claimed against our state hospitals for malpractice? Then, in terms of the board and the establishment of the board, would you say that we certainly need to look at health experts that serve on the board as well as from the medical society and civil society, and that Parliament should really be the watchdog in terms of establishing that board and making sure that that board is a capable board and plays its role as expected within the health sector, and Parliament has the oversight and the appointment role in terms of that instead of the minister. Can I ask you, would you think that the bill in its current form would pass constitutional muster in terms of rights? And then, in terms of health facilities, 5 out of 696 health facilities currently comply to the 80% pass mark set by the department. Do you think that once the NHI bill is implemented, that our health facilities would benefit in making sure that our standard is far better? And then I just wanted to ask, sorry, I have to find this one question. Okay, that hang on, here it is, yeah. Section 5.5 determines that in order to register as a user of the fund, a person is required to provide his or her biometric information and an identity card, original birth certificate, or a refugee identity card issued in terms of the Refugees Act. However, it is common cause that not all person that would ordinarily be eligible to use the fund would have birth certificates or identity documents. Do you think it's recommendable that the bill make provision for those unable to produce birth certificates or identity documents so they are able to be admitted as users to the fund until they're able to produce such documents? And I'll tell you why I mention this. I often do oversight at many of the schools within my constituency, and there is a real problem that many children do not have birth certificates, and that, that the school battles to get Home Affairs to come and make sure that they have, the adequate legal documents in order to access benefits. Can I ask you, would you think that that should be provided within the bill as well? I thank you.
Honorable Sengwa. Honorable Sengwa, are you there? If not, we will move on to Honorable Ismail. Are you available? Honorable Slengwa and Ismail. If not, I have a number of points I want to talk about, because you mentioned quite a number of things, Dr. Malherbe. The first one is about the referral pathways. And I know that you do have a bit of a displeasure with that, with Section 7.2D. And just to remind you of what the NHI white paper says, that you can relate that, your understanding of that. It says that patients who need to be treated by specialists or in hospitals will have to be referred by primary health care providers, certified and accredited public and private hospitals and specialists. This means, except in emergencies, patients cannot go straight to the specialist or to a hospital. Now, we understand, and I do know that it is quite current practice at the moment by some medical schemes with regards to managed care or care coordination for all patients with chronic diseases. You also recommend that we should consider the health market inquiry recommendations. Are you aware that on utilization and benefit design, HMI panel recommended care coordination through a referral system from primary healthcare level to higher levels of care? And then on the next point is about your concern that people with congenital disorders and rare diseases will not be catered for under the NHI, and what makes you believe that the Benefits Advisory Committee will not accommodate into the benefits package those services required by patients and individuals in need of care, for example, rare diseases and genetic disorders. The next point speaks to your concern about the provisional funding framework that must be put in place prior to drafting the NHI bill, and whether you have looked at clauses 48 and 49 on sources of funding. Have you also considered what is contained in the memorandum of objects accompanying the bill in section 3? If I'm going too fast, you can please tell me. Paragraph 3.2 in particular, on sustainability and affordability of NHI, and section 8 on financial implications for the state. Furthermore, have you looked at and familiarized yourselves with what is contained in chapter 7 of the 2017 NHI policy dedicated to the finding framework for NHI? Then I've noted what you said, that the private sector is already full, or your word was full of positions, meaning that most of our healthcare providers are in the private healthcare sector. And isn't that exactly why there's a proposal in the bill that services should be purchased from both the private and the public providers? And do you believe that, or rather, let me put it, you seem not to be aware of the fact that in the spirit of point 4 in your conclusion, the NHI bill provides for comprehensive health services that covers all users, irrespective of race, whether they're rich or poor, including promotive, preventative, curative, rehabilitative, palliative services, regardless of socioeconomic or health status. If you can just give me a little bit understanding of your view of that. And very lastly, you have raised concerns about sections of the Act which deal with medical schemes, and a point was made about the powers of the registrar as far as they covered in the Medical Schemes Act. That is how the registrar may limit the extent of benefits to users. The question is, how are the patients with rare diseases accessing healthcare services now, if according to the presenter, even in the private sector currently, these patients seem to have treatment access challenges, and the Medical Schemes Act has provisions that make it difficult for them to access the care they need. And we do know that is quite a big concern. And you have, for example, used the example of adolescent scoliosis, and when a surgery is required, by when it should be done, and all the other treatment, including braces, etc., physiotherapy, occupational therapy, etc., that is required. That's a very good example, because that is an example of the cost factors involved in the type of diseases or patients you work with, where the diseases which you talked about. Thank you very much for that. You are free to answer those questions.
Chairperson, I'm back.
You're welcome, Honorable Sengwa.
Yes, Chairperson. Thank you very much, Chairperson. Thank you to the presenter for the very informative presentation and a very touching one. I have one question. In your presentation, you highlight that the contribution of congenital and rare diseases are increasing, but it largely remains unseen as there is a lack of empirical data, and therefore the scale of the health issue is completely underestimated, which has a knock-on effect on services and access to relevant care. From your own research, do you have any data on the scale of the health burden of this disease to understand the impact of the lack of detail on the bill on provision of such services? Thank you.
Thank you very much.
Chair, may I?
Are you back also on Isma?
Thank you, Chair. I just have a few questions. Firstly, I would like to thank the presenter for a very, very informative and, touching presentation. I think it's very, very important. We sometimes forget about special needs in the country and in the health sector, and, it's very, very informative. So thank you. I just have a few questions. One, do you feel that since the NHI pilot projects were unsuccessful, another pilot study should be implemented besides before the implementation of the NHI, especially taking into consideration, chronic patients and, special needs patients? If I could put, your presentation into perspective under special needs. Secondly, do you feel that the bill in its current form provides effective healthcare to our country? My third question, you refer to the issues raised via the referral pathways. Now, I know your presentation was quite, frankly stated to say about constitutionally, biasness and so forth. So would you say that, the NHI bill as it is now is actually infringing the rights of patients, especially with regard to the disability that you highlighted, and, it constitutionally incorrect and therefore should not be implemented until everything that you highlighted is actually addressed? So that means that you would not support the NHI as it is, or would you support the NHI? I just wanted clarity on that. And you highlighted, that the Office of the Health Standards Compliance can't cope. Now we do know that, the Office of the Health Standards Compliance doesn't even monitor 20% of our healthcare facilities. And we know that, most of our facilities are in dire straits and in a pathetic state, if I could put it that way. Would you then recommend in your submission that these, infrastructure issues should be actually, upgraded in, everything in the health system, if I could say, whether it be healthcare workers, the numbers of healthcare workers? We know there's a shortage of doctors and nurses, and we know that community service doctors and nurses are actually crying, waiting to be placed. And most especially, with regard to special dispensation, like in the needs highlighted by yourself. So would you then say that all these should be addressed before the NHI can be actually implemented? Or would you rather say that while implementing the NHI, all these matters could be addressed? Thank you, Chair.
Those are all of the members who wanted to raise questions with you, Dr. Stuklesi, Mr. Stuklesi and Dr. Malherbe. Please continue to answer these questions.
Thank you very, very much.
We will go on lunch at 2 o'clock. Thank you.
Perfect. Thank you very, very much, and thanks for a great round of questions that we look forward to just clarifying our position on many of them. So I think if I can, just as a starting point, you just highlight that with regards, because I think it forms a significant basis of our point of view, with regards to the system currently with being a dual healthcare system. We are in no way supportive
of continuously supporting a further divide in terms of equity by means of that very system, and we see it on a daily basis. But I think that the committee might be under the impression, or certainly the honourable member who raised the questions, that we are of the view that the private sector does better for our patients than what the state sector does, which would be a gross misunderstanding of our position in this regard. We have, without a doubt, seen that there can be absolute great care provided in the state system, if not the best care provided in the state system. We have great access to multi-systemic teams. We have fantastic referrals within the team. You find a patient is often being treated at one centralized point, which makes communications between the various members of the healthcare team much easier. We've seen the referral systems within that particular academic and tertiary hospital setting to be highly improved. And certainly the passion and the academic knowledge from a healthcare professional's perspective is really most of the time far superior to what we see in the private sector. Furthermore, we have significant access challenges in the private sector. The difference is that the private sector has the ability to litigate. And as a result, patients are actually not able to advocate, I think, as well as they would be able to in a state facility. What we do see in the state facility is, in many of the state facilities, comes down to purely budget, which is quite a, it's quite a simplistic thing to understand. You can only do with what you can do with the budget that's in front of you. However, in the private system, we find that the funding is in fact there. You are merely needing to jump through an enormous amount of bureaucratic hoops to actually get access at the end of the day. So I just wanted to clarify that we are in no way supportive of continuation of a dual healthcare system, and would certainly like to see a healthcare system where, regardless of who you are, where you are being treated, you would have access to the same level of services. So that is the first thing we wanted to clarify. With regards to Honourable Dr. Harvard, with regards to the bill being in the current form and the role of the Benefit Advisory Committee, it is our opinion that that Benefit Advisory Committee needs to have extensive consultation and inclusion with civil society and patient representation. From our understanding, the Benefit Advisory Committee, how it has currently been set up in the existing formats, that has been certainly to our understanding, we have the opinion that patients have not really, or are not really, going to be given the opportunity to participate. And when it comes to unfamiliar, vulnerable communities in healthcare, and certainly unknown rare conditions or complicated conditions, it is common practice in medicine that the patients have lay expertise that are simply not relatable from a clinician's perspective, or not even easily understood from a clinician's perspective, because a lot more goes into treating and understanding these conditions than simply healthcare. And furthermore, these conditions are not only isolated to being healthcare problems, but also have a much larger impact when it comes to social support, education, disability in the workplace, general accessibility, etc. as well. So this is why we have our comments with regards to the Benefit Advisory Committee. We do not feel that it will be sufficient in the event that patients do not have the ability to feed into that system, and that there is no patient representation, either in the form of patient advisory groups or civil society representation. But we do feel that that is absolutely necessary, and that that team cannot merely be focused or be maintained or have members that are purely from a healthcare academic and healthcare professionals perspective. With regards to Honourable Sekocha, no reference, you commented with regards to no reference to the mechanism, to the financial framework, and questioned, if we were aware of the provisional funding framework in the white paper. Yes, we are, but again, we feel it is still insufficient. We understand that a large proportion of the financial funding pool will come from existing taxpayers. Our concern with this is that the tax base in South Africa is exceptionally small, And we have to ask ourselves, with the amount of taxpayers currently funding that are currently putting into the existing tax base, what efforts will be made to increase that tax base, because it would be somewhat impossible to take that same pool of funding or that same pool of taxpayers and expect them to do more. Furthermore, with regards to the funding framework, with regards to the existing members of medical schemes being able to contribute further, it is common cause from our understanding and based on our research within our members, which might be disproportionately skewed, obviously given that they are all chronic patients to begin with. But there is a clear understanding from our perspective that those patients would not be able to contribute to both. So there wouldn't be this top-up facility or the ability to continue funding in both your medical aid capacity as well as the existing capacity. So if we needed to redirect funds from the medical schemes perspective in the private sector into the public sector, we would need to know that we would still get the same level of benefit outside of that payment, which is the point that we were trying to make in that regard. With regards to Honourable Chiletsi, seeking clarity with regards to the service benefits and complementary cover that is not included in the NHI. I think I have touched on it now with the previous question, but the top-up cover for us is a concern even within the existing system at the moment. We are applying for comprehensive benefits, not just top-up cover. We are still seeing an access issue with regards to patients being able to access innovative and high-cost technologies, which unfortunately for the rare disease population are generally the only treatments that are available. So we don't have the benefit of having choice. We will very often only have one treatment available in the entire world, and those treatments are generally not necessarily the cheapest drugs on the market due to the obviously extensive research and developments and low patient pools that is available to recoup those costs. And if we are currently seeing access issues to these particular products, when you are accessing comprehensive benefits, we are unclear as to how we will be able to still not only maintain, but improve, which is, to our interpretation, the whole point of implementing NHI is to provide this overhaul of the healthcare system. We need to be wanting to move forward and not stagnating. So we cannot see how it will be possible simply from having access to top-up cover where financially viable, which is also going to be limited, will actually resolve the access issues that we currently experience. With regards to the post-COVID-19 comments, I think it is very, very important to stress that this is, and I'm actually very, very excited that it was raised, because if anything, COVID has taught every person in this country and on the planet what it is like to be a rare disease patient, in the sense that we've experienced isolation, we've experienced stigmatization, we've experienced what it's like to be denied an opportunity to work, and the associated economic impact of being impacted by a condition. We've experienced the loss. We've experienced the need to be better caregivers in our own homes and taking care of those that are vulnerable around us. We've learned what it's like to have to be consciously, acutely aware of picking up infections and being immune compromised, etc., in your everyday life. And most importantly, we've learned what it is about to have to unite as a global community towards trying to benefit others in terms of healthcare. We've all sat waiting for a time that a vaccine would become available. We've all sat with the trepidation and excitement, wondering about when the research and development would be at the point that something would get FDA approved. And we have certainly seen what can happen when the world rallies together. So from a rare disease perspective, I think everybody is a little bit more enlightened now. The only difference is our pandemic's not going away. For the majority of our patients, we are in it for life. I say we are lifers without any form of parole. This is going to be our future indefinitely, and we would like to see a community and an engagement going forward that addresses all these issues. So I really do, whilst we understand COVID has had significant impact, that impact is felt by us from the very time we get a diagnosis to the last living day that we have, simply because of all the complications that come with having these conditions. And again, these things are not simply healthcare issues, they are also social issues. Social welfare is required, social support, mobility, accessibility, education, disability in the workplace, all of those form part of actually giving a rare disease patient a fair shot and giving them some form of equity in terms of society in general. So do we support the two-tier system? No, we don't. Are we aware of the fact that a limited amount of our population, being 16%, access private care? Yes, we are. But again, we are not under any form of illusions that that is the better approach, because we have certainly seen, and we live every day with advocating for patients who are not able to access services, even with pools and pools of funds and benefits available to them. With regards to Honourable Member Clark, the question was, do we have enough HCPs? And I think Helen will also be touching on this. Do we have enough HCPs in the system to deal with them? What we have seen in the state sectors is that there is certainly enough academic knowledge. What we don't see is a continuation of that knowledge or any set services and plans in place to ensure continuation of that type of knowledge. So we would like to see improved training in that regard, and we would like to see improved collaboration amongst different tertiary clinics and hospitals, etc. And I think that it's a very, very important thing for us, because it ultimately, it's not a rare disease patient's treatment doesn't come down necessarily to the doctor's knowledge. It's about everyone in the ecosystem, including the patient's ability to discuss and make informed decisions that are suitable for that particular patient. It's not a one size fits all approach, unfortunately. With regards to the medical legal issues that we are currently seeing, do we anticipate that it would reduce and dissipate the rife amounts of medical legal claims that are out there? We would like to draw the committee's attention back to the elements of patient consent. If a patient has been properly engaged and has been participatory in the decision-making process throughout, they are less likely to take any form of legal action when they don't receive the outcomes. It is from the cases that we certainly have seen where medical legal implications have come up and cases have then been taken further. It is most often the case that the patient feels that they were not consulted, and therefore they become bitter and agitated with adverse effects. But if the game plan and is clear from the very, very beginning, and everybody within that ecosystem has a fair amount of understanding as to what the long-term goal of whatever treatment it is that is required is, we generally find that the patient's willingness or desire to take further legal action is reduced. Lastly, with regards to the improved training of the board, the medical advisory board, these are not conditions that you can train people on. You have to live through them to understand. And as time changes and more treatments, etc., become available, so does the level of education and the things that are needing to be carried across in the education space. So for us, this is another very important reason why patient expertise are absolutely critical in terms of that advisory board and the functioning thereof and the knowledge that is brought to that board when making these decisions. With regards to would it be best to remove the board from the minister and move it into a parliamentary space? Yes, we do feel that that would be a better suggestion. We feel that that there would need to be improved oversight and accountability as well with regards to the overall functioning of those boards. With regards to will the bill in its current form pass constitutional muster? I think it's a question we ponder over. We do feel that there's elements that would, but again, we feel from if you look at it from a position of minority or vulnerability, we do feel that there's elements that it's not to say that the bill is intended to be intentionally unconstitutional, but more not enough has been mentioned or not enough has been included in the framework to give vulnerable members an ultimate right within the framework. I think is probably a better way of phrasing it. With regards to the users of the fund needing to register, I think that therein is a prime example of how the framework needs to include things that are sometimes out the box. And we absolutely agree that all members, regardless of a variety of circumstances, need to be able to find mechanisms to be able to benefit from this registration. And if an ID card is what is required, then certain efforts need to be made with regards to making those services available and accessible to the vulnerable communities. And that mustn't include, as an example, fingerprints. What do we do with patients who are double amputees who do not have fingerprints? With regards to, there's a variety of eye issues, disability issues, all those sorts of things. So we need to be able to think out the box, and we need to have more than one mechanism to be able, many ways to skin a cat. We need to find the various ways with the end goal of being registration. With regards to Dr. Jacobs's questions around referral pathways, the existing system as it is not entirely different. Patients are needing in the public sector, in the private sector, yes, it is surely different, but for purposes of answering this question, we're going to stick to what we know in the state sector. Various referrals are needed, and we are not against the referral system. We encourage referrals. The issue that we have is that the referrals are not taking place, or they are so complicated and they are so labor intensive that it almost discourages anybody from actually making the referral. And that is currently the issues that we have. And most importantly, the time for the referral process is often not conducive to healthy outcomes. If it takes a patient 18 months to get referred from a clinic in Timbuktu to actually being referred to at the likes of the Johannesburg Hospital, etc., or Baragwanath, if it takes them 18 months to get there, obviously the clinical picture has changed significantly during that time. So we need, and the patients very often actually have passed away by the time we get there, particularly with the very, very aggressive conditions that we see early on. So for us, the referral pathways are necessary, but the mechanism that needs to be implemented to make it effective is where the work needs to be done. And with regards to sustainability on the NHI and the financial implications on state, yes, we know that there will be financial implications. We are under no doubt. And we also know that the pot is limited. I suppose the question comes around with the existing funds that are available to state are, at the moment, as we sit here today, are not necessarily well accounted for. We still have copious amounts of corruption within the system, and we have service delivery issues. The PPE during COVID was a prime example. How do those elements go away? We could already have a much more improved system with services that would be far more available and greater healthcare outcomes in the event that we eradicated the corruption and the misappropriation of funds that currently exist in our system. So we are not seeing any solutions necessarily to that problem within the framework, and it remains a problem. And I don't think anybody who experiences or has to use the system could argue that they haven't been negatively impacted by the likes of corruption and misappropriation. And then with regards to the medical schemes and the benefit limitations and how patients are accessing services currently, as I have stated, yes, there are issues within the system currently. Access is not guaranteed in either system. The difference is in the medical system, in the private system, if you've got good legal representation and a good understanding of the law, you are generally able to advocate better, whereas in the state system, you simply just get that there is no funding available. And with regards to the Medical Schemes Act and the changes that have been proposed within the Medical Schemes Act, in terms of providing the registrar with the ability to impose these benefits and limitations, we still do not feel, and we have provided submissions to this effect as well, that the Medical Schemes Amendment is currently suitable, and that it is currently also going to do what it is set out and intending to do. So with that, I'm going to hand over to Dr. Malherbe, who I think will have some final comments to these questions. Thank you. Thank you, Honourable Chair and Honourable Members. I would just like to come back to the point raised by the Honourable Thengwa regarding the scale of the health burden relating to congenital disorders and rare diseases. So this is an area of data. There's a huge data deficit in literally all low middle income countries. And we have been going about looking at best practices globally and looking at modeling as an interim tool so that we can generate estimates of what these of the impact of these conditions and the birth outcomes and how it can actually impact our population. So there is some work that has already been published last year for South Africa at a provincial level for a number of congenital disorders and rare diseases, and there are further papers coming out that are peer-reviewed also on specific conditions, for example, Down syndrome, oral facial cleft, neural tube defects, and so on. And we also do include oculocutaneous albinism because of the higher birth prevalence that we have in South Africa as compared to other countries. So that work is underway, and the next step of that work is now we've quantified the burden of disease, we actually need to cost the services that are needed to serve those populations, and that's where an area that we're working on now for our research. I would also like to add to the point that my colleague raised regarding healthcare professionals and are there going to be enough in the system that are able to support it. And I think, and it was also relating to the consent issue and the malpractice issue. And I think ultimately both of those speak to the need for increased capacity and standards and quality standards being implemented. So I think obviously there is ongoing health professional development and so on to maintain registration with the HPCSA. But I think we need to also think out of the box a little bit there, just to ensure that the capacity building speaks to it. And it's not just a tick box exercise to get a certain number of HPD points to maintain registration. We need to actually have some innovative ways of getting the appropriate training. For example, to reduce the malpractice cost for cerebral palsy, for example, at birth. There's a huge body of evidence out there now showing that a lot of cerebral palsy is congenital and it's actually caused in the womb and not at birth. So I think capacity building by all the stakeholders involved, including, of course, the healthcare professionals and providers themselves. The other issue I wanted to point to was regard to building that capacity. We're almost becoming unethical in South Africa in terms of we're training people up, but there's nowhere for them to go. So as it was pointed out by our honourable member, that we've got a lot of posts that are being frozen. So you have genetic counsellors being churned out by the system, achieving their masters, and then there are no posts. So that's one of our tasks, one of our roles is to advocate for those posts in province. But currently we've actually seen a huge reduction. We did used to have services in 4 provinces, but the services are actually getting worse. They are being further neglected because while they were first through that 2001, that was an excellent document outlining what we needed for South Africa. But with the impending burden of other infectious diseases, for example, the HIV, AIDS, and concomitant TB pandemics, a lot of the funding was then frozen and rediverted because that health need was imminent. But now we're coming to grips with HIV. We really need to rationalize and look back at our other health priorities and start funding those posts again. And the genetics community is in agreement, which is why we had come up with, together with the National Department of Health, with a revised genetics guidelines document on which I was a key author, that we need to get these services in place, but we need to have the funding allocated for it to be implemented. And my final point, apologies. Yes, I just wanted to come back to the point with regarding access to, health standards can't cope and so on. And 20% of, sorry, I've just lost my place.
It was relating to the question around infrastructure issues and upgrading facilities and healthcare providers and so on. We had a case in point last year when the riots occurred in KZN. We had a number of our patients that lost all of their prescriptions, all of their health records were destroyed when doctors' offices and blood banks and other places were destroyed. And they literally could not access care because they didn't have access to their records or scripts. And it really highlighted that issue in terms of they need to have access to those healthcare records, but there needs to be some kind of continuity through an electronic healthcare system. And the other issue is that early diagnosis and access to care is an imperative for people living with these conditions. For example, congenital hypothyroidism needs to be diagnosed at birth through newborn screening. The medication only costs 44 Rand a month. But if undiagnosed, those children lose IQ points every day and become physically well and mentally challenged and live with that disability for the rest of their life. But if it's diagnosed through a simple test at birth, which is currently not available in the state system at all and only very limited in the private sector, we can actually be saving lives and adding to our socioeconomic benefits. And in terms of these services, I think we need to start these upgrades immediately. I don't think we have a reason to wait around until NHI is fully implemented. We need to start getting our houses, our collective houses in order now so that we can make an impact on patients, whether they've got congenital disorders, rare diseases, or a common disorder. They need to have access to appropriate, safe, effective services immediately or as soon as possible. We thank you.
Thank you very much. I've really enjoyed your presentation and your answers you have provided, but you also didn't tell me between the two of you that you'd won so many awards. I just happened to go and look up. Modesty is good. We thank you for advocacy and the use of evidence-based medicine to apply solutions for people who suffer with genetic challenges and rare disorders. So with that said, I'm about to say goodbye to you. You have a last opportunity, maybe just to say something very shortly, and then we will then adjourn for lunch.
I think just to say thank you very, very much again for the opportunity. And once again, we would like the committee to know that we are committed to doing whatever we can from our side to make our healthcare system work. And it's not a case of we like to be constructive in our approach and our feedback because we're all working towards a common and a unified goal.
And to add on to that, I would just say we don't see it as a you and us. We very much see it as a together us, that we're in this together. And the only way that we're going to make a difference is by working together. So we're on the same team and we're always looking for better ways to partner and engage with you. So we thank you for this opportunity.
Thank you. We appreciate being on the same team with you. Honorable members, we are going to adjourn for lunch. We will be back at 14:30. Please do not switch off your devices in case you're going to struggle to join us again. And you're also welcome, our two presenters, to stay on and listen to the other presentation, but you're also free to leave this platform. We will be back at 25 minutes past 2 in preparation for our next presentation, which would be Saktu at 14:30. Thank you. Enjoy your lunch.
Recording stopped. Recording in
Honourable members,
progress.
thank you very much. We are about to receive a presentation as a continuation of this morning's meeting, which is oral representations on the NHI public bill. Please be reminded that all the rules of the National Assembly apply, and we will then just make this a continuation of, as I said earlier, continuation of this morning's meeting. All honourable members are then assumed to be present at this time after lunch. And I will also then go forward and welcome the South African Clothing and Textile Workers Union to this presentation. And I had seen a number of the leaders on the platform. If the leader, Andre Kriel, yes, I had seen you on the platform earlier. Very welcome to you and to your team. And we're looking forward to your presentation. You are welcome to introduce the rest of your team and then to go into your presentation. I do see I still have 2 minutes before you're due to start. Maybe in that time you can just do the
introductory things. Okay.
And then we take the presentation from 14:30.
Thank you very much, Chair, and good afternoon to the committee and all the other colleagues. We want to say that we appreciate the opportunity to do our presentation to the Portfolio Committee. I have my colleague that you now see on the screen here. His name is Simon Eppel, who is a senior colleague in our trade union, who will do the presentation on our behalf. I want from the outset to say, Chair, that we are obviously not medical specialists, but we have a wealth of experience on how primary healthcare has been managed in our industry. And we will try to come straight to the point as quickly as possible, so as not to delay the committee and not to waste your time. So, Chair, we are, ready. I see it is 2:30, and if I could, with your permission, then invite Comrade Simon just to do the presentation on our behalf. Thank you, Chair.
Thank you.
Thanks, Honourable Chair, Honourable Members. Good afternoon to you all. Thank you for the opportunity to present. If you can just confirm that the presentation is in front of you.
Yes, it is. Thank you. Maybe you can just put it on slide. There we go.
Okay. Honourable Chair, Honourable Members, just a very, very quick overview on SACTU, since we're giving you a sense of the experience and insights that we bring. For colleagues who don't know, honourable members who don't know, SACTU is one of the COSATU affiliates and trade unions. We are also affiliated to the Global Manufacturing Trade Union Industry All, which has got 50 million workers in that organization. We have in our own union about 126,000 members across the country, predominantly in the clothing, textile, footwear and leather manufacturing sector, so the factories. And there, our presence is in roughly 1,500 factories, but not exclusively so. We're also in other workplaces and other sectors, laundry, agriculture, farming, forestry, agro-processing, retail, etc. The members who constitute SACTU are invariably very low-waged workers, predominantly Black working class women, often in the poorest parts of the country, supporting, roughly 5 dependents, often single breadwinners. At a headline level, Honourable Chair, SACTU supports the NHI bill, and really the motivation there being, we see the significant opportunities and the step forward that it brings around the lives and health of the working class in South Africa, and the opportunity and access to the provision of decent, affordable, timeless healthcare. And I think that position, honourable members, it's aligned to the COSATU position, and I understand the COSATU presentation hasn't happened yet, and so the fuller sense of the position of our federation will be coming. For our purposes, Honourable Chair, we want to just narrow our input to a specific thing. We want to focus on the fact that we think the bill should recognise bargaining council clinics as accredited healthcare service providers under the NHI, and that's really the intention then of this presentation. Honourable members may be aware of bargaining councils, some may love them, some may not, but regardless of your feeling towards bargaining councils, there are many, and some of them operate healthcare facilities for workers. Separately to that, in tandem, many unions may do the same, but the architecture and services and infrastructure that the bargaining council clinics in particular bring, we think, and we want to make the argument to you, that infrastructure and services is firstly very valuable, and secondly should be harnessed for the NHI. So a sense of what are the healthcare interventions that we may make as a union? There's really two levels of them. We've been involved for many decades. The reason being the union is looking for ways to add to the well-being of its members, the workers who constitute the union and their dependents. And so, broadly, this dual structure of intervention, the one is indirect forms of healthcare assistance. So take, for example, in the clothing industry, where SACTU, not directly, but indirectly through the structure of the Clothing Bargaining Council, and in collaboration with employees in the industry, has been providing forms of primary health care since 1942, primary health care, dental, optical services to workers, but also the management and provision of chronic medication and support to workers. It's not solely in the clothing industry. It does exist in other industries too. For example, in the leather and footwear bargaining council, they also have primary healthcare for workers. And then, separately to an indirect channel to workers, we also have direct channels of well-being support to workers. For example, for roughly 2 decades, we've run a very extensive HIV/AIDS, TB intervention that deals with awareness training, testing and treatment. Focusing just more narrowly on the Clothing Bargaining Council and those services, that basket of services. The way it's constructed is that through the council, through the finances that it raises, there are 10 primary healthcare clinics in the Western Cape, parts of KZN and Gauteng. And those have medical professionals who provide services to workers, and some of the services are outlined in a moment. And presently just over 50 medical professionals, but then also spaces provided for medical students who provided a basis for internships and sort of a platform for experience. And then separately to the clinics and the direct medical professionals that are employed through the bargaining council healthcare system, there are 100 or roughly 100 what we call panel doctors, and those are doctors who are contracted to the service to provide free on-demand assistance and care to workers. So, judging just before COVID and sort of the up and down of lockdowns and workers at work and not work, in 2019, pre-COVID, roughly 200,000 direct consultations were provided to workers for free, and that's roughly what it is on average every year. So it's a substantial input and intervention that's made for workers. The kinds of tools, the kinds of interventions, the kinds of assistance which is provided, various health screenings on blood pressure, glucose, cholesterol, HIV/AIDS, pap smears. There's treatment of acute and chronic conditions. Then there's management and testing and things like HIV/AIDS STIs, TB, where, you know, various screenings, testings, and treatment are provided. I mentioned earlier the dental and optical services that are provided, but there's also physiotherapy services. There's also social work services on top of that. So it's a larger basket of primary health care. Obviously, the dispensing and management of medicines. There's the home-based care opportunities. There's the workplace health interventions. In other words, not waiting for workers to present at the clinic, but reaching them outside of the health space, hopefully before disease sets in, to mitigate and manage the arise and onset of disease and illness in the first place. Then there's services that are provided to industry retirees. And so I suppose, you know, general healthcare awareness promotion, general primary health treatment visits, etc. But there's also an adaptability to the system, and you know, maybe a good way to outline that is just to take the COVID pandemic, for example, where a very acute need to manage and then dispense vaccinations. Obviously, the accreditation of, you know, vaccinators, healthcare staff, to take on the duty of vaccinating workers, and then an extensive campaign both to bring workers into the clinic, you know, as they needed, but also, you know, sequentially through factories. And the end result was, and this is the last time we had done this audit and it was provided, was that at the end of November last year, you know, roughly 74% of the clothing workers serviced by the industry clinics had been vaccinated. And it was a significant achievement, honorable members. It's more than double the national average at the time. So it shows you that the model, both of flexibility and penetration into communities through this kind of model, works really well. And that's one of the arguments we want to make, is that the systems like this, the bargaining council clinics, carry very unique strengths. You know, physically they are located close to workers, in working class communities, you know, close on the transit routes of workers, close to the industrial hubs, etc. But they're also located in another sense within the industry by virtue of being comprised of the members of an industry. The ability to, I said earlier, read the room, the ability to respond quickly and effectively. And it means that these institutions are known by workers. They have good social capital, they have good social networks, they have good knowledge, and can provide and enable efficient rollout of interventions. And as I mentioned earlier, not all of that has to be as workers present or as citizens present at the clinic. Some of that is preventative. It can get workers before they manifest contract, etc., disease or illness. Why we think that's useful, why we think these clinics are useful, is because, you know, they offer an opportunity to alleviate the operational burden on the Department of Health in various facets: disease prevention, education, treatment, etc. And we would argue that in some senses they're an ideal clinic model for the NHI and worth piloting. So just to the last slide, Honourable Chair, you know, our sense, and I've mentioned that we want to be quite targeted and specific in this presentation, but our sense is that the bargaining council clinics, as they stand, provide a good opportunity, framework, infrastructure, intervention model for the NHI, and that they should be, you know, incorporated into the NHI. But currently the bill doesn't, and we believe it should, explicitly recognize them as accredited NHI healthcare providers. So that's the big ticket issue we want to bring to you. There is something we would flag for the committee, which is that the construct of the LRA, particularly section 28, subsection 1G, limits the services that a bargaining council, which is an institution comprised of parties, it limits the services of that institution to the members of that institution. And that would create a challenge in the event that bargaining council clinics play a broader role in the NHI, because obviously they would need to service the larger citizenry. And so, you know, we may need to just consider, the committee may need to consider, you know, whether there's a need then to propose and amend parts of the LRA sufficiently that it allows for the adoption and the explicit recognition of the bargaining council clinics as NHI service providers. And lastly and finally, Honourable Chair, honourable members, you know, I think we want to flag as SACTU our belief that the bill really needs to incorporate very vigorous mechanisms to prevent fraud and corruption, both at the level of the NHI fund, but also at the level of procurement. I don't need to, you know, flog a dead horse. We all know the extraordinary and distressing scale of corruption that exists, and we think that the bill will need to take suitable measures. It's got to recognize that the baseline of fraud and corruption is unconscionably high, and is going to have to institute measures to make sure that it stamps those out and doesn't allow them to occur. On that basis, Honourable Chair, if I can close the presentation and hand back to you. Thank you.
Thank you very much, Mr. Epple and Mr. Creel. Is that your entire presentation?
Yes, it is. That is our presentation. I'm sorry if it is too short, but we didn't want to mess you around.
Yeah, no, fully understood. Thank you very much. It's just that I have not been able, I've not seen any members indicate yet. I have now one. Honourable members, please raise your hands. You can even shout on this platform. I have one member so far, Honourable Munyai, who has indicated that he wants to raise something with SACTU. Honourable members. Honourable Hubbard is number 2. Honourable members. So I will start with Honourables Munyai, Hubbard, then Ismail. I am delaying a bit to see who else wants to raise some questions with you, with yourselves. And I don't see any others coming up on the other platform. Honourable members, you can shout here, and I will take you in the order that you shout your names. If not, we're going to start with Honourable Munyai, followed by Honourable Hubbard, and followed by Honourable Ismail, and then myself. If there's any other honourable member who wants to then still raise something, you should raise it after Honourable Ismail, so that I will be last. Thank you very much. Honourable Munyai, please start.
The first question, does SACTU support the National Health Insurance and also the object of the Act within the reflected in the bill? Or SACTU want the two status quo or dual status quo to remain, you know, where the medical private sector really have 8% to GDP, accounting to over 400 billion, and yet they save the 16% of the rest of the population, and the rest of the population, including public sector, don't have access to that fund. And most of this funding is not going to really healthcare services, but to non-core medical services, such as the administration and so forth of the medical aids. Second question I want to understand, you have also requested that civil society should participate in the NHI structure. Does Section 27 not address your consent? If you can go through that. The bill states that, just for ease of reference, open quote, the minister must, after consultation with the board and by the notice in the Gazette, appoint a stakeholder advisory committee comprise of the representative, including organized labor and civil society, close quote. This is coming from the bill section 27. I thought maybe it's important if you're not aware of it. And so, but this is the two questions. I may come on follow up. Thank you, Honorable Chair.
Thank you, Honorable Chair, and also thank you, Presenter. From my side, just one question. Would the sector be amenable to their clinics being used by the surrounding communities to access health care services? If so, is there a specific model that they would like to share with the committee on how other committees in the surroundings? Thank you.
Good afternoon, and thank you for the presentation. I just have a few questions. The first question, we know that the tax base in South Africa is relatively small. Do you feel that the pool of taxes will be sufficient to carry the bill to provide for effective healthcare services to the country? My second question, do you feel that with the current shortage of healthcare workers and we know the issues of placements of doctors and nurses, and we know the dilapidated state of our infrastructure, of our healthcare facilities, will the NHI really work? Or do you feel that, the placement of doctors and nurses should be done first? That means, the full complement of healthcare workers. And do you feel that the upgrade of infrastructure should be done first before the implementation of the NHI? My third question, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our healthcare facilities, and the fact that health facilities need to reach certain compliance requirements, do you feel that this will adversely, affect the availability of clinics and public healthcare facilities? Because we all know that, 90% or at least 80% of our healthcare facilities will not be, eligible to be functioning under the NHI. How do you look at this with regard to the implementation of the NHI? Now, we also know that, access to quality healthcare for all is very crucial. Now, to what extent do you feel the bill allows for equal access to quality healthcare? In your opinion, is this an all-inclusive bill? Do you feel like the NHI bill in its current form will be providing a health value-based model? This is in regard to sustainability. Do you feel that the bill is sustainable? My last question, we know of the corruption that has taken place, and obviously also with COVID, if you're looking at the digital vibe scandal with the previous health minister, do you feel that, external people or more, I should say, entities of healthcare professionals should be sitting on the board? And when you're looking at oversight, the oversight tool, what would you recommend towards the bill to be, who should be on that oversight? Who should, for the oversight mechanism to be strong, who do you suggest or who do you recommend to be, the people doing the oversight on this NHI bill? My last question, do you feel that the bill will stifle innovation in the healthcare sector? Thank you.
Thank you very much, honorable members. Any other member who has not had an opportunity to raise his or her hand? I want to speak to you about your suggestion that there should be a concerted effort made to apply or to strengthen community-oriented care in reserve models. It's actually very welcomed, but I also want to just refer you to section 7.2D of the bill, which does address your concern. I'm just going to read it. the section, and it says the user must first access healthcare services at the primary care level as the entry into the health system and also adhere to the referral pathways prescribed for healthcare service providers or health establishments. I would like to hear your view whether you've noted that and whether you might want to comment on it. And then you've also made proposals for bargaining council clinics to be retained under the NHI so that your members should be represented by the organization whilst using the current approach when it comes to offering healthcare services. Question is whether SAC2 facilities are not intending to participate as accredited healthcare service providers under the NHI, and if so, why would they adopt such a position? But most importantly, I'd like clarity with regards to what is it that makes SAC2 believe that the members will not be taken care of adequately under the NHI for their healthcare needs. And then you have also proposed there should be amendments to the Labor Relations Act of 1995. So the assumption is that these will enable funds to be redirected to the NHI fund. If you'll be able to give me clarity on that. So if you can clarify how funds are generated through the bargaining councils, the council parties to fund healthcare services provided by your clinics, that would really assist, and also in the same vein, to clarify the reimbursement method that you use to pay your healthcare professionals for the services which are rendered, and whether this is based on salaries, fee for service, capitation, etc. And how do you manage to maintain sustainability of the funding that you receive? Thank you very much. Those are all the questions raised. You are free to respond. Thank you.
So thank you, Chair, and thank you to the questions from the members of the committee. I will answer some of them, and my colleagues may want to add where I may have missed some. I think the overarching point that we'd like to make, though, right from the beginning, is that we are very clear where we stand on the issue of the NHI. By making this presentation here, and the input that we're doing must not be perceived as that we are seeking protectionism and exclusivism for the system that we currently operate in our industry. When my colleague Simon Eppel started the presentation, one of the very first points that we made, which I think was very clear, is that there must be no doubt that we fully support the NHI, its objectives. We think it is long overdue. So there must be, I think, Member Munyai and also Chair yourself, and to some extent, Member Ishmael, we want to make that point, very explicitly and very clearly. When the question is asked, do we want the status quo to remain? By the status quo, Member Munyai, we assume that you mean the status quo where it is nationally and not necessarily for certain, outside our industry, and not necessarily referring to the healthcare model that operates in our manufacturing industry, in the clothing, textile, footwear, and leather sector. Not at all. Now, we would want to say that the healthcare clinics that we operate are not medical aids. It is self-funded clinics, self-funded by the industry, and not even registered under the Medical Aids Act, because it is registered under the Labor Relations Act. So it's not a medical aid. But at a national level, we think that we will make a general point. Our federation will speak more about this. We think the fact that the largest number or the largest proportion of our population is excluded from healthcare is a sin. It's something that we should all be ashamed of. We think that the NHI implementation will help to resolve that issue. When we come to the issue of the civil society section, thank you for drawing our attention to that. We will look at it a bit more closely. And if we have any input on that matter, because we're trying to just focus here on the issue of the relationship between industrial health, industrial self-provided healthcare and the NHI. On the issue, Member Howard, of the clinics and the surrounding areas, what specific model would we want to suggest? Again, I'm going to make the generic point that we currently, our healthcare clinics services our industry, but that is not our vision. And we think it's not a vision that is generally shared by employers because these are co-managed. It is bipartite institutions. We would prefer that there be broader access to our communities, to our healthcare clinics. So it's not an exclusive domain that we'd like to maintain going into the future. On the, you've asked quite a number of other questions. Simon can answer some of them, but I want to just make a general point that hopefully generically answers your question. We think that the NHI, or we think that the health infrastructure development, including human capital, medical staff in other words, cannot be seen as a sequentially, as something that needs to be developed sequentially. That is not our view in SACTU. Other people may have different views. Our concrete experience shows that when you develop these things side by side, that actually it becomes more effective and actual implementation instead of theoretical postulation works better. To debate endlessly and then never to do anything is a problem to us. So yes, there will be a problem maybe in infrastructure, but as you implement new healthcare systems, you fix it. You don't first fix and then think everything will be perfect. The chairperson of our Clothing Bargaining Council is the CEO of PEP Manufacturing, the clothing company in Epping in Cape Town. When we signed our first collective agreement dealing with a hard lockdown right at the beginning on income support for workers, there was a lot of criticisms. And then she said something very profound, which is, if we wait, nothing will ever get done. If we do, yes, we'll stumble, we'll not be perfect, but we will fix the issues as we go along. The same has happened with the provision, with the manner in which government has handled the issue of COVID. We stumbled, but it's getting better. We saw it with the problem at the beginning of that we had with a vaccine availability. We stumbled, but it's getting better all the time. It's because you learn from the lessons when you implement things in the concrete. So the same with the NHI. The problem from our point of view is everybody waits for perfection, and in the meantime, people die of poor healthcare provision or non-healthcare access provision. So I know, member, I may not have answered your questions very directly on the specifics that you've answered, and that is deliberate because I do want to give an indication that we support the NHI objectives 100%. And it is not something that gets developed step by step. I'll give another example. We think with the vaccine rollout provision, for example, that's something that should be located as part of the development, concrete development of the NHI. On the issue of the sustainability, yes, we think the NHI can be sustainable. Our federation will deal with that a little bit more. On the issue of corruption, Simon has dealt with that very clearly early, but I want to repeat, the scourge of corruption in our society must be condemned in the strongest terms. It's robbing the poor from services that they deserve. And the problem with the healthcare provision, we've seen it in the PPE provision, for example, is that there must be strong mechanisms to combat that. And we've got ideas which we'll put up in a different forum. I'll fast forward now because I don't want to speak too much. Simon also want to say some things. But on the issue, Chair, that you've raised about the bargaining councils and members represented and all of this and the accredited facilities, our healthcare clinics were never geared for the provision and dispensing and administration of the COVID vaccine. But we built that infrastructure and we built it very quickly. And now we are accredited and we're linked into the national database and it is globally recognized. So just this coming Friday, we will have a high-level visit from national government and from the World Health Organization and from, the Belgium embassy to one of our sites of administration. It is because we recognized that there was a deficiency in our infrastructure when we were confronted with a new challenge, and we built that infrastructure and we didn't spend millions on it. Today it works not perfectly, there are hitches, but it delivers the outcomes, which is high output, high levels of vaccination. Now, the same can be done with any other healthcare provision in terms of infrastructure, which links me back to the earlier questions that Member Howard has asked. On the LRA amendments and the funding mechanisms, Chair, it is self-funded, it's not a medical aid. But there is a contribution from employers and there is a contribution from the workers, direct deduction from their wages, and it is managed through, let's call it an independent facility. In other words, the union doesn't control that money, it gets controlled in a bipartite way, which helps with, with everything. But I would like to put it like this, the funding of the healthcare clinics is actually deferred wages by workers. What do I mean by that? When we do collective bargaining and you reach a settlement, whatever percentage it is, then you carve up where that settlement must go to. Some of it goes to take-home wages. Some of it goes to the provision of industry benefits, such as in this instance, healthcare. And that is simply how it is funded. Now, obviously, it requires an eye to detail, because you don't want to tax workers indirectly in the manner that this healthcare provision is being funded at the moment. But workers don't see it like that. When the Social Security Green Paper was published, you know what outcry there was. We don't have that kind of outcry. And for one reason only. It is because the contributions that the workers make and that the employers make, and, the employers' component being actually workers' deferred wages, is not seen as a tax because there is value-added services linked to it. In other words, they feel they get quality service. Not the greatest, it's not like 5-star medical care, but they know it is a trustworthy service that they can give. Now, I just want to conclude by saying, we did say right at the beginning that what would be preferable is that the healthcare clinics at the moment be opened up to communities. It's located in communities and it can grow from there. What we do want to prevent, though, is that by the introduction of the NHI, that the system that we've built over many decades gets killed instantly. That will be a disaster. Chair, I'll pause there, and maybe my colleague Simon would like to add to what I've said. Thank you very much.
Thanks, Chair, and thanks to my General Secretary. I think he has broadly responded to most of the questions. There's just a couple of smaller little ones that I could pick up. So, for example, Honourable Ismail, I think it was, posed a question about, who should constitute the oversight committees, etc. Look, I mean, I don't know that we've got a firm position on exactly the constituent members, but I think our experience and our observations in this kind of realm, in other situations, suggest you can't populate the governance structure just with your friends. You need to have sufficient representation from parts of society, even if some of those parts, are not your besties. And that the members who participate in oversight are sufficiently skilled. Now, sufficiently skilled doesn't have to mean that everyone has a PhD or a master's degree or even a formal degree. I mean, one may have strong feelings either way, but certainly there are people who, through experiential learning and being in situations of deep responsibility, etc., may have those kinds of skills. So I'm not suggesting we put a requirement on formal education necessarily, but absolutely it can't be friends. And it needs to be sufficiently representative into society, and there needs to be people who are sufficiently skilled to be able to call out the challenges that may exist in the system. There's an interesting question posed on, whether the NHI would kill innovation. And Honourable Chair, Honourable Ismail, I was surprised at the question, and reflected on it, and I guess my assumption is the question is posed on the basis of an assumption that innovation sits primarily in the realm of the private sector and that the public sector is not innovative. And, it's not clear to me that that's necessarily true. It's not clear that the private sector is necessarily innovative. And certainly, I think there's an emerging a strong body of literature and research coming out about the role of the state in innovation. And perhaps you're acquainted with it and perhaps not, but essentially the argument being that the state actually acts as a market shaper in terms of innovation far more regularly than we give it credit for. So whether that will allay your concerns or the concerns of the member sufficiently, I'm not sure, but I'm not sure that binary is necessarily true. I do see a question from the chairperson, Honourable Dr. Jacobs, around the reimbursement of, and I assume it's panel doctors. You've asked, what's the reimbursement method? Perhaps my General Secretary can respond to that in more detail, but my understanding is it's a pay for service or fee model that's adopted. And I'm assuming that the chair is asking that because you may be considering the type of payment models rendered under the NHI, but perhaps my General Secretary can respond more directly to that. Otherwise, I don't want to take the time of the committee. I think my GS has sufficiently answered many of the questions. Thanks.
Thank you very much. Do you want a second bite, General Secretary?
Doctor, not necessarily, but I just want to keep things very simple. When you see people in the poorest parts of our countries, in the poorest communities, and you see other people that are privileged to whip out their medical aid cards and get, medical aid, medical service coverage. That inequality breaks the heart. It is not right. It's not the kind of society that we should build. That's the general point. We think the NHI will play a role. It won't be perfect, but we think if it breaks that unequal access to the provision of healthcare, and it is primarily located to service where it is most needed, which is in the poorest communities. That's why our clinics are located there. We'd have done well as a country. On the funding model, whether a dual model is preferable or not, we leave that to Matthew when next he comes and does the Federation presentation. That's not our concern. We only just make the generic point. But then, Chair, on the matter relating to the payment methods, on the panel doctor system, well, it is a paper issue where there is no cash that changes hands between the patient, which is the worker that goes and see the panel doctor. It's basically on a invoicing basis to the bargaining council on a preferentially negotiated rate. That is how it works. And then there is a regular payment. Remember, the contributions here does not come to the union. It comes to the registered healthcare fund, which is managed separately. And that is how, so there's a invoicing system, and then there's disbursement and payment. What we do want to say, Chair, is that they are mindful of time, that there is a lot of goodwill amongst many medical practitioners towards workers. And the reason for that is that many of them have roots in the communities that they service. And that's why, and it's decades of relationships, in particular in the clothing industry, and it's all interrelated. For example, there are many doctors because they've received a bursary from SACTU, and that helped them to become high level medically qualified. Many of them, over many years, we inject probably close to about 15 to 20 million rand in bursary support for the members' children of the children of the members of our trade union. People would never have access to higher and further education. And we see many instances, sometimes I just I just keep it simple, Chair. I see, that doctor from Mannenberg, the guys like helping all over the show. And, he could only become a doctor because he was supported by the money of workers. There are many of them like that. And that's the kind of goodwill that a system like that works. Now, I don't know how it will work with the NHI. I don't know whether it will have the same goodwill or whether or not it will just be a money spinning machine, which indirectly I hear you asking. And if I'm very direct, are we not making this presentation because you see a money making opportunity for our healthcare clinics? The answer is no. If we wanted that, we would have converted it in complete private healthcare, which we've got access to as part ownership, elsewhere. But we don't. That's not what we want, Chair. Obviously, you can't provide a service. Let me put it this way: the dispensing of the vaccines and all of that at the moment, that's open to the communities. Open to the communities via our clinics. It's not just only ring-fenced for members of SACTU. Chair, I don't want to go on and on and on. I just want to leave it with a simple conclusion to the committee. Let's do this. It is needed for our country, and in the process of doing it, let's not kill good services on primary healthcare provision that have been built up for poor people, like industrial clinics. There isn't just, our one, as Simon has said, There are many healthcare providers located within workplaces. And this has got to be a complementary system. Chair, let me shut my mouth there at the risk of saying some wrong things, but thank you very much. We are here if there are any further questions or information that the committee requires from us.
Thank you. We are a bit earlier. I'm going to ask any members if they still want to raise a follow-up question. If not, I have one or two things to say to you. Thank you very much. Honourable members, any of you whom I have missed, because we do have a bit of time, and I'd love to use this opportunity to hear more of the wisdom of our representatives here from the labour organizations. If not, just in closing from my side, General Secretary and also Mr. Epple, I think the understanding here is that we explore through asking questions. And we have heard many presentations before. This is about our 104th or 103rd presentation, just oral submissions having been made. And therefore we get a broad understanding of what is really happening. It is eye-opening to have you come and present today and for us to be able to ask those questions as to how does this work. Because I am aware that there are those primary healthcare clinics which are operated, for example, by SACTU. My father was a member of the Leather Workers Union many, many years ago. And I remember him being able to go to certain doctors and to get assistance. And yes, I do know about the support which labor unions give to many students, the children of the employees. So it's very commendable. So I just wanted to also bring to your attention that it is good for us to hear the answers which you provide and to hear what the role is of those particular primary health clinics within the communities, and how do you see it ought to be going forward as the NHI is implemented. And I would think that maybe more discussions will probably follow. And as you're saying that the Federation will come to also do a presentation, and there might be some extra answers to all of the questions which are raised. So with that having been said, let me thank both of you for coming, and also thank your trade union for coming to present to us. I'm going to allow you an opportunity to maybe make a closing remark, and then we will move on from there.
Thank you, Chair. I'll be brief. Whenever we do these presentations, we don't do it for ourselves. You think of workers like Nokutula Tlatswayo, who gave birth to twins on the factory floor in Newcastle in KZN, and who died. And the only reason for that is there was no proper protection, no proper access to, to basic medical services. It breaks our hearts. And I know the committee might think that I'm invoking emotions, but that is, that's the truth. That is how ordinary people, struggle. Chair, I'll leave it at that as a closing comment and extend our appreciation to yourself and to the committee for having afforded us this opportunity. We are fully aware that we may have not have answered all the questions directly, but we wanted to give you a sense of where we think things should head to. And we wanted to present to you an opportunity. We might not have presented it perfectly, but there are opportunities to strengthen the NHI and healthcare delivery by linking into existing healthcare infrastructure. They don't service the rich. and that works and that people have confidence in. Thank you, Chair.
Thank you very much. You are welcome to stay on and listen to the rest of the presentations, but you're also welcome to leave the platform should you so wish. Honorable members, we are looking for the next presenters. They're not on our platform yet. They are to start. We're actually running a bit ahead. To have started at 15:45, and we had asked them to join us a little bit earlier. I think for now you can take a 5-minute break, and I will ask Ms. Majalamba to inform me as soon as South Africa joins us on the platform. And then also just for your noting that the Master Builder South Africa has withdrawn the presentation, which would have taken place at 1700 hours. And we would then after that receive the Professional Providence Society. We would of course see if we can get them a little bit earlier if possible. If not, we would then take a break again after the presentation of the People's Health Movement of South Africa. So a little bit of indulgence from your side. And thank you very much again, General Secretary Trill and Mr. Apple. We'll take a short break, honorable members.
Hi, Kenneth. My surname is Sinisipo Jojo. I am the representative for the People's Health Movement. I think some of my colleagues are still to join. I see Ilroy is here from the People's Health Movement, but we were under the impression that we are presenting at 15:45, but we had to be present 20 minutes before the presentation. That was our allocated time, Chairperson.
Yes, thank you very much. That's what we understand. That's why we were hoping that you would be here earlier. And thank you very much for actually being here, but earlier. You are supposed to start at 15:45. But when you are ready, you can please introduce your team. I didn't get your surname. I think you said Jojo.
Yes, Chairperson.
Thank you. When you're ready, just give me an indication. You can just speak on the platform and introduce the team, and you can go straight to doing your presentation.
Okay. Chairperson, do I have an opportunity to wait for my team to join at 15:45?
Well, I was actually hoping you'd be able to start earlier, but if you don't have a choice, we did ask you to join 20 minutes earlier, but yes, I mean, I do understand that you have been given an allotted time, an allocated time. So if it's not possible, it's entirely up to you. We would appreciate your presentation. So yes, you can make that decision.
Chairperson, I'm just communicating with my team. I will let you know soon.
Thank you.
currently. So there's a lack of detail about upgrading the public health system. We will elaborate on this a little bit further. There's also a possibility of exacerbating inequality between the private and the public sectors, as well as between those who live in the rural areas and those who live in the urban areas, and those who have and those who don't have. We also know that there's failure in distinguishing primary health care as well as primary care, and this will be elaborated on a little bit further. We know that there's a lack of adequate mechanisms for civil society engagement and no accountability in the NHI committee structures. This is particularly dealing with decision-making, influence in decision-making, rather than token participation. We also know that there's lack of emphasis in capacitating the public health system through a pro-public NHI. We're very concerned about how the NHI fund itself will be allocated to actually invest in the public healthcare system, especially with the current structures, especially with involvement with the private sector. We also caution against the possibility that universal healthcare coverage could be reinterpreted as a reinterpreted corporate private healthcare industry to facilitate profiting from the NHI fund. We are concerned that the NHI fund essentially will be just kind of another medical aid scheme, will be run like another medical aid scheme. We are also concerned about the narrow focus of UHC potentially weakening the action of social determinants of health. We're also worried about the level of control of the NHI fund vested in the Minister of Health, as I think of the Section 27 as well as TAC have highlighted in their presentation. Just struggling to get to the next slide. So our first emphasis really is on fixing the public sector. And in this, we mean that without a well-functioning public healthcare system, the NHI cannot succeed. The most recent report of the Office of Health Standards Compliance found that only a fraction of the public health facilities surveyed met the norms and the standards required for the NHI certification. It is therefore imperative to fix and upgrade the broken public health system to the level that is required for NHI accreditation. The bill gives no detail on how to do this. This could possibly exacerbate inequalities. Private facilities are not only more likely to get accredited, but also overwhelmingly urban-based, thus increasing both urban and rural and private-public inequalities. Furthermore, registration of benefits of the NHI must be done at an accredited health facility, which then issues the user with a registration number and physical evidence of membership, and maintains a register of all users and dependents. This poses yet another risk that those already marginalized in society from access to care, such as rural populations, the disabled, the foreigners, the elderly, will further be disadvantaged. Facilities that already lack staff, medicines, equipment will not find it easy to register users as smoothly as those facilities already functioning at a higher level of efficiency. Many public sector facilities lack easy internet access. There is also a possibility that people living in some of these areas will not be able to access NHI-funded healthcare facilities, as in our introduction of Sipho and his mother, who live 60 kilometers away from the nearest facility. So we conclude that in order to facilitate a well-functioning NHI, we need to fix and we need to upgrade the broken public health system. The second point we'd like to elaborate on is the risk of exacerbating and entrenching inequalities. Registration for the benefits of the NHI must be done at an accredited facility. And often people like Sipho and the mom are not able to access these facilities. And this speaks of partial inequalities, uneven geographical distribution of clinics that makes registration for rural people, particularly the elderly population and the disabled population, very difficult. We saw this example during the COVID times, that people in rural areas, the elderly as well as the disabled, were not able to access vaccinations on time because of spatial inequalities. There's also unequal distribution of funding between the private and the public sector. There's poor infrastructure that makes it difficult to register designated providers in the public sector. Public sector facilities are often overcrowded, under-resourced, understaffed, and undermanaged. And so this, and it might be difficult for particular individuals to register at these facilities if there's no upgrade that is provided, if there's no investment to actually make these facilities better, if there's actually no work that is actually done at those local facilities to actually make the registration process work, even the people accessing the healthcare work. So this speaks to unequal distribution of funding between the public and the private providers. There's also inequalities within the healthcare force. Without an explicit commitment to regularizing the work of community healthcare workers, the NHI will not be able to address poor wages and insecure conditions of services of these workers, who are the foot soldiers of the PH system and the primary healthcare system. Drawing as well from our lessons from COVID-19, we know that it was the community healthcare workers that went from door to door, facilitating the work of the the work of COVID-19, whether it was through surveying, whether it was actually through contact tracing, whether it was actually through providing sick and the needy who were not able to access healthcare with healthcare services. We know that it was the healthcare workers who were often the foot soldiers, really, in this COVID pandemic. But we'd see no commitment in this NHI bill that speaks to addressing the issues that actually affect the community healthcare workers. And we think this is a gross inequality within the healthcare force. We also see that there's unequal decision-making powers. So we do acknowledge that there has been some civil society involvement and organization early on in the process since 2016. And we do welcome the invitation that we have received today for a parliamentary participation on our submissions that we made 5 years ago. But we still are concerned about the weight that our input will make in terms of in really restructuring the current national health insurance bill as it stands, as well as restructuring the current national health bill process so that it's actually pro-public and it actually meets the needs of the people that need it the most. Our other concern is really the confusion between primary health care as well as primary care. So primary health care in the bill is really mentioned as kind of the first point of service. So in this particular case, it would be the person, SIPO, going to the clinic, and that would be the primary care facility where he receives his primary care. From primary care, he could be referred to a secondary level hospital or even to a tertiary level hospital. But this is not what PHM is advocating for. PHM is advocating for a primary healthcare model, a primary healthcare approach to healthcare. And this is a developmental approach to health that goes beyond the health system. It emphasizes comprehensive healthcare by the health sector, but it also addresses factors that cause poor health. So it incorporates the social determinants of health. It incorporates the root causes of why people fall ill, and it also seeks to reduce the burden of disease. And indirectly actually assisting the healthcare system. It emphasizes meaningful community participation in health-related issues. This includes planning, provision, evaluation, as well as healthcare services. PHC also recognizes that health for all is achievable within PHC recognizes that health for all is unachievable within an unfair current global economy order that entrenches inequality within and between countries. Why is it important to have primary health care in the context of national health insurance? Community participation helps to optimize health interventions at an organizational, community, and individual level to improve public health. It also helps in priority setting as well as in the developmental organizational relationships and trust. It gives a sense of ownership within the community. Health services are responsive to local needs with more effective use of resources as well as better health outcomes. Community-based health workers and properly functioning health committees play a crucial role in facilitating community participation. It also incorporates intersectoral action, which addresses crucial social determinants of health that could reduce the burden of disease, as well as lighten the burden of health services enormously and free up resources for key programs that demand the National Health Insurance Fund. Notably, common intersectoral actions include expanding water and sanitation, provision and improving education, adequate housing, reducing social economic inequalities, promoting gender equity, involving women in policy formulation and progress implementations. Furthermore, the global ecological crisis threatens to overwhelm all efforts to deal with the social determinants of health unless we make rapid progress. The Department of Health should therefore advocate strongly for collaborative action on social determinants of health by other sectors, and this can only happen under the umbrella of primary health care. Participation is really key to the right to health. And South Africa's white paper on the transformation of health services in 1997 argued in its mission statement that it is essential to obtain the active participation and the involvement of all sectors of South African society in health and health-related activities. The National Healthcare recognizes in its preamble that the purpose of the Act is to establish a health system which encourages participation. South Africa, in a party to the ICESR in terms of the right to health, framed in a general comment 14 as an inclusive right extending not only to timely and appropriate healthcare, but also to the underlying determinants of health, in which a further important aspect is the participation of the population in all health-related decision-making at community, national, and international levels. To realize the objectives of the NHI, which are universal access, primary healthcare, primary healthcare, prioritization of community needs, there needs to be effective community participations, particularly in the NHI bill, the Benefits Advisory Committee, as well as the Pricing Committee. This will achieve accountability, better alignment of benefits to community needs, avoidance of dominance and overemphasis on curative care, counterbalance to the influence of the private sector in shaping benefit packages to their interests. Participation in stakeholders' advisory committee is necessary, but it is inefficient as the current national health bill stands. Advisory committees have limited powers. The white paper refers to mechanisms for the participation of people in the national health system will be established at all levels, being part of necessary democratization of South African society. This is far more than just advising. The National Healthcare Act recognizes the obligation of the national department to promote community participation in planning, provision, as well as evaluation of health. This is far more than just advising. This is also emphasized in the stakeholders' consultations should not just be a rubber stamping process. Clear terms of governance and lines of accountability to stakeholders' advisory committees should be included within the NHI to ensure that the Minister of Health and related officials are mandated to engage with this body and ensure the recommendations are not ignored. The participatory structures of the National Healthcare Act are ignored. In the bill or in the National Health, in the NHA, the NHA creates provision for community participation in health services through the establishment of the hospital boards and clinic committees. Clinic committees are meant to include community representatives able to express and voice the local communities' needs in relation to the health system. This is so inconsistent with the primary healthcare approach and the direction of the white paper, which states that the health system should establish structures to promote community participation at the level of the community, as well as national, provincial, as well as district levels. We also, in terms of participation, we also have identified that there could be conflicts of interest. And this leads me to my next point, where we emphasize on the building and the capacitating of a pro-public NHI, pro-public a health system. We've identified that the private sector, as well as the pharmaceutical hospital industry, have underlying, always most of the time have different underlying interests to the public sector, even if short-term convergence can be induced through payment arrangements. If ignored or left on its own devices, the private sector will gravitate to protecting and promoting its own interests by virtue and the nature of the market. If the NHI is to be pro-public, it must remain committed to a principle of independence from individual benefit. This is with a rights-based health system. We cannot achieve universal healthcare coverage if NHI structures afford private sector interest groups disproportionate influence. This has been the experience of other countries seeking to implement NHI-based UHC without careful attention to regulation of the private sector. There is a known growing body of evidence that only a public funded and publicly administrated healthcare system can be sustainable, reliable, equitable to deliver healthcare to populations most in need. Considering this, the NHI should use its purchasing power to specifically and consciously capacitate the public sector. It is vitally important if the fund is to purchase from both public and private providers, because as we have seen in recent past, it is possible for the purchasing of private sector services to further decapitate the already weakened public system. While in the case of individual general practitioners or specialists, this may be less likely, there is a real danger that powerful private hospital groups may benefit from NHI contracts and resources which could have been used to upgrade and staff public facilities to fulfill the same function. We therefore strongly motivate that any private hospital contract should only be entered into temporarily and with public sector public sector investment as a key principle. This, for example, could mean including the requirement for skills transfer to public sector workers and ensuring that the private contracts are not entered into if public facilities if a public facility is able to perform the same service. Private hospital providers should be measured against their ability to constructively interface with the and capacitate the public health system as a criteria against which their future eligibility for the NHI contracting is measured. These would be our recommendations. Nearing to the last point, we just wanted to speak on that the bill is not clear on its interpretation of UHC health coverage. And UHC is really meant to imply that all people and communities have ready access to promotive, preventative, curative, rehabilitative, and palliative healthcare services that they need, equitable access. And that services are sufficient, of sufficient quality, they're effective as well as efficient, and that the use of services does not expose them to financial hardship. This is in line with the founding principle in the Constitution that all citizens are equally entitled to rights and privileges and benefits of the citizens. The bill clearly states that addressing the barriers to access and the structural challenges to the health system in schedule repeal and amendment of legislation affected by acts. It's open quote, healthcare should be seen as a social investment and not be subject to trading as a commodity. The universal healthcare coverage system is a reflection of the kind of society which we wish to live in, one based on values of social solidarity, equity, justice, as well as fairness. The bill establishes the National Health Fund as a single purchaser of comprehensive healthcare to achieve UHC. UHC implies that all people and communities have ready access to what they need. The understanding of health as a social investment and a common good rather than a marketable commodity is essential to UHC. It means UHC is a means of building society based on values of social solidarity, equity, justice, and recognizes the principle of health as a fundamental human right. As mentioned in the bill, achieving UHC will require public financing based on social solidarity, where the young, relatively wealthy, and the healthy citizens cross-subsidize the elderly, poor, and less healthy through progressive tax-based single-payer system. However, some context in this meaning of UHC, powerful, well-funded corporate groupings with vested interests in highly profitable private sector and free market fundamentalists argue coverage in UHC allows for scheme-based insurance models, which voluntary with voluntary prepayment and a range of financing mechanisms that inevitably discriminate against the power of the poor and the least healthy. They have mounted a pressure and possibly well-coordinated media campaign hostile to the NHI project. Common campaign themes include resistance to single-payer systems, arguments for expanded private sector, as well as scheme-based involvement in health services delivery. They present little, if any, evidence that substantial private sector involvement facilitates progress towards an equitable healthcare system and social solidarity. On the contrary, a substantial body of empirical evidence shows that to realize objectives of universality, equity, particularly in the South African context, social solidarity, attempts to UHC must, from the start, address the needs of the entire population as well as the whole healthcare system. Okay, and I covered in my previous conversation. And just our last point on a narrow focus on UHC that may weaken the action against social determinants of health. There's a risk that the state will narrow its focus on UHC and neglect the importance of dealing with the root causes of ill health through intersectoral action to address unequal access to social determinants of health. These include the elimination of poverty, which is reflected in SDG 1, adequate food and nutrition, quality education, gender equality, water and sanitation, the reduction of inequality, promotion of environmentally responsible consumption and production patterns, and mitigation of climate change. While some of these goals rely on other sectors, the state has shown little evidence of its ability to promote intersectoral collaboration. So this calls for all states to be involved. But unless leadership on intersectoral action emerges from the presidency or the Department of Health, it is unlikely that it will be achieved. It will be achieved. Particularly the Department of Health, we advocate, should actually play a role in actually bringing these sectors together to discuss how lack of water and sanitation affects people's health, how improper roading infrastructure, in the example of SIPO and the mother, actually affects people accessing health. In conclusion, the NHI in its current form represents an alternative funding model for the healthcare of South Africa. For this funding model to result in a new health system, which is based on the principles of primary health care, it must deliver equitable, quality care that is community focused, but it will require much broader reimagining of our interventions on social determinants of health and our health services. To build this vision of health and healthcare in South Africa will require the involvement of a broad range of role players, from community health committees and social movements to clinicians, academics, public health specialists. We call for a transparent, democratic and accountable process as we collectively embark on constructing this new vision for the healthcare of our country. Thank you.
Thank you very much for that presentation, People's Health Movement of South Africa. We have a number of honorable members that want to engage with you on what you had presented, and I'm going to name them in the order that they will raise those questions with you. It's Honorable Sgela, Sukacha, Howard, Ismail, Munyai, Clark. Gela, Sukacha, Howard, Ismail, Munyai, Clark. Any other honorable members who want to raise any questions? If not, honorable members, please continue and raise your points. Thank you.
Thank you very much, Chairperson. Let me first welcome the presentation. I've got a few questions that I want to ask Chairperson. Firstly, thank you for the comprehensive presentation. May I request further clarity from People's Health Movement regarding the statement they have made in their presentation to say the provisions of the NHI bill do and will continue to marginalize members of the civil society. My specific question is that, Chairperson, how does the NHI bill create marginalization? If I can get a response or more clarity. My second question, Chairperson, since the role of clinic committees, hospital boards, district health councillor are prescribed in the National Health Act, is it a PHMS view that Chapter 5 of the National Health Act must be amended? The other question, Chairperson, the concern around primary health care and primary care is unclear. Has the PMS PHM familiarize itself with the provisions of the NHI white paper regarding the service delivery model within an NHI environment. Lastly, Chair, okay. No, those are the questions, Chairperson, that I wanted to ask. Thank you very much.
Thank you very much, Chairperson. Just two questions from my side. Let me also welcome the presentation. My first question, People's Health Movement is of the view that the public sector is broken and the private sector is perfect. Hence, PHM holds a view that only private facilities will be accredited under the NHI. My question then is, Chairperson, on what basis does this very interesting blanket view of both the public and the private sector come from as described by the presenter? Then my next question, Chairperson, is there a firm proposal from PHM of how stakeholders advisory committee could be constituted to be regarded as inclusive and participatory? Thank you very much, Chairperson.
Thank you very much, Honorable Chair. I just have one question. Does the PHM believe there is no need to introduce universal health care coverage policies in South Africa? What is your view on a single payer, single fund? Thank you.
Good afternoon, and thank you for your very thorough and interesting presentation. I have a number of questions. My first question, to what extent does the bill allow for equal access to healthcare? Now, in your opinion, is this an all-inclusive bill? Would you say that the NHI bill in its current form will be providing a health value-based model? Bottom line is this bill a sustainable bill in its current form? My second question, we know the tax base in South Africa is relatively small. Do you feel that the pool of taxes will be sufficient to carry the bill to provide for effective healthcare services to the country? My third question, I noted you stated in your presentation that infrastructure must be fixed. Now, do you feel that with the current shortage of healthcare workers' placements and with the infrastructure crisis, if I could call it that, NHI will really work? Do you feel, I know you highlighted that the infrastructure must be fixed. I want to confirm, do you think we will access quality healthcare if we don't ensure first that we increase the amount of healthcare workers in the system and improve our health infrastructure before the NHI is implemented? My fourth question, don't you think that a single purchaser model is going to cause a monopoly, thus increasing prices of medicines? My fifth question, considering that the Office of Health Standards and Compliance presently can't manage to monitor even 20% of our healthcare facilities, and the fact that health facilities need to reach certain compliance requirements under the NHI. Now you spoke about primary healthcare and this is our clinics. So many of our clinics will not meet NHI standards. Do you feel that this will stifle or impact health services to communities? My sixth question, under the bill's current governance and organizational structure, do you recommend the private sector be included on the board to improve the accountability and legitimacy of the board? What outside oversight measurements do you feel should be included so that we can mitigate the threat of corruption? Do you feel that the bill will stifle innovation in the healthcare sector? Now, you have prioritized and mentioned public in decision-making over and over and over in your presentation. How do you feel the public should be more involved in the bill? What is your recommendation? We know that there's health committees and hospital committees and so forth, but really in the bill, what would you recommend for us to include the public sector in the decision-making? Because if you're looking at the amount of public healthcare facilities that we have, whether it be hospitals or clinics, there are so many. How do you include each and every one, on the advisory committee? Where do you want, how do you want this included in the bill? I just want your opinion on this. Do you feel that under the NHI, most of our professional healthcare workers will leave the country? And I see you highlighted the issue of special need patients, etc., etc. Do you feel that the referral pathways, are very labor intensive and could negatively impact timelines and adversely affect the health of patients? Thank you, Chair.
Honorable Munyai. Honorable Munyai, you are next.
Thank you very much, Honorable Chair. Firstly, the organization said that the chapter in the Republic of South Africa. If they're the chapter, where is this organization headquarters? And since in the 70 countries that they exist, for instance, did they contribute towards policy reform? Did they contribute towards, in the UK, for instance, NHLS reform, which is like the NHI here? Did they participate in the US Obamacare? Did they participate in Australia health reform policy? If they can give us example, whether they did so. If they did so, if they didn't do so there, why here? But okay, let me proceed. You have raised the concern of the NHI bill, focuses not only on universal health coverage at the expense of social determinants of health. Since the bill is focusing on covering personal health care services, as opposed to non-personal health care services, what is your movement proposal on how the funding for programs aimed at addressing the social determinants should be coordinated? Just another question, Honorable Chair. It is unclear that your organization implies that it asserts that this universal health coverage might facilitate profiteering from the NHI fund. Which provision in the bill creates the possibility of this risk? And what is the proposed change to ensure that this doesn't happen? You seem to want a universal health coverage without the NHI. Can you clarify?
Thank you very much, honorable members. Any other member who would want to still raise any question?
Chair, I was last on the list, I think.
Oh, yes, you are right, Honorable Clerk. Please proceed.
Thank you, Chair, and thank you for the presentation. It was a really interesting presentation. So what I would like to emphasize in terms of issues raised in the presentation, can I just raise an issue around the NHI grants that we receive that is meant to be to upgrade universal health care in our system? So in 2020, the Treasury shifted 1.4 billion rand out of NHI in direct grants received, which funds the majority of NHI projects. At the time, the Treasury said the cut was due to slow spending on contracting with general practitioners, mental health services, and oncology services. Similar cuts were imposed in 2019 when Treasury moved 2.8 billion Rand in unspent NHI funds to the provinces so that they could fill critical posts. The medium-term budget policy statement now sees the Treasury cutting 308.4 million from NHI indirect grant, trimming the allocations for 2021-22 financial year from 1.34 billion to 1.03 billion. The February budget allocation, 7.5 billion to the NHI indirect grant over the medium-term expenditure framework. This includes 986.3 million to fund contracting of healthcare services, 2 billion to strengthen the health system in preparation for NHI, and 4.4 billion for infrastructure projects. So year on year, the NHI grants that have been given to the health department in order to strengthen our health system has not been realized. 3.8 billion Rand was spent on pilot projects, and that has not, the outcomes of those pilot projects have not been factored into this bill as to realize positive outcome. So access of healthcare is a right, and I agree 100% with you. Everybody in our country should have access to quality healthcare. But I also think it's a right of yours, a human right of yours, to choose who you would like to use within that as a healthcare provider. And it should be your choice to go for a second opinion. And I, you know, as my colleague, Honorable Ismail spoke about referral timelines, now I'm concerned, you know, how lengthy that process would be, and would there be any recommendation from you in order to propose a referral system that would be fast and would benefit people in this country. Do you believe that the current universal health care can be fixed? And how do you suggest this is done? Do you believe that the NHI bill can realize its outcomes with the current state of hospitals, pointing out again, and I mentioned this to previous presenters, that only 5 out of 686 hospitals were compliant in the terms of the 80% ratio of the health department? And what would you suggest? You have made some recommendations how to fix the current healthcare system. If there's any suggestions, any further suggestions to ensure that the current system we have is upgraded so that we can actually supply healthcare throughout our country, quality healthcare throughout our country. And, you know, there was an issue spoken about global healthcare. Do you believe that, you know, if you look at global healthcare and the current environment hospitals function within in the global sphere of things, do you think that South Africa competes in that same structure? Thank you. And sorry, Chair, just the other issue, which was also mentioned in the presentation. Would you say that if Parliament had to play a far more progressive role in terms of establishing the boards and the committees, that would you feel that that would make that process far more transparent? Thank you, Chairperson.
Thank you very much, Honorable Slengwa. We can't hear you, Honorable Slengwa. And I also can't see whether you're muted. Maybe just have a look if you're muted. We can't hear you, Honorable Sengwa. Not yet. Unmute again now. Unmute again, Honorable Sengwa. We can't hear you. Maybe check your volume button also. I tell you what we do. I will ask some questions and we'll come back to you, Honorable Sengwa, while you check out your volume buttons, etc. All right. Thank you very much also for your presentation, PHM. Now, you've raised some concerns regarding the fact that you believe that there are provisions with the bill that you believe are inadequate in addressing the healthcare challenges of our health system, which were highlighted, as I said, during your presentation. Can you provide us a proposed wording of the changes that you think should be reflected in the bill? And in your areas of concern, you highlight that there is a lack of detail about upgrading of the public health sector. Do you delineate between the jurisdiction of the objects of the National Health Act against the objects of the National Health Insurance Bill? And you also raised in your presentation that an incremental approach to implementation of the NHI will be opposed by powerful dominant groups. We have previously received submissions from some of the hegemonic players in the private sector, cautioning the committee on an accelerated pace of implementation of NHI and that the implementation must be prolonged. How do you respond to this view from from the private sector with regards to what I just mentioned? And then finally, in relation to the question raised by Honorable Bonya, it's about the same topic, but not necessarily the same question. Can you please provide examples of countries where they have waited for their health system to be fixed before they could implement the health financing legislation? And is it not essential that through NHI, the financing of the health system can be improved to achieve the weaknesses that you have identified in your presentation? I will go back to Honorable Sengwa now. Let's see if we can.
Thank you, Chairperson.
There you go. Thank you.
Now I'm audible.
Yes, you are.
Thank you very much. I have two seeking clarity questions. Number one, you speak about the unequal decision-making powers. Can you elaborate on that so that we are all on board? Number two, you talk about primary health care is a board, and you continue saying meaningful community participating in issue-related health. I'm a little bit confused about that, and I'm very concerned hearing about this meaningful community participating, and you even talk about the clinic committees, where when we deal with about the public hearing in the provinces, we do meet the clinic committees, but you are going to tell us more about what you mean about this. Lastly, if you can clarify, what do you mean about rubber stamping? Are we rubber stamping in doing this? Or who is rubber stamping somebody? Let us get clarity on that. What do you mean about rubber stamping? Thank you.
Thank you very much, honorable members. You've heard all the questions raised by the honorable members, Sinesipo Jojo from PHM. You're very welcome to respond. Thank you.
Thank you, Chair. We just wanted, so we welcome all the questions, very interesting, very intriguing, and we are happy to engage on all of those questions. We're just a bit overwhelmed by the number of questions. It's coming close to 25 questions, and I'm concerned about time. So we only have 15 minutes. But can I submit to the panel that we would submit a written response to these questions, because we are enthusiastic to really engage in some of these discussions, but we don't think 15 minutes will give us sufficient time to respond adequately to some of the concerns that are raised on this platform. Can we get a response?
I would expect you to answer as many as you possibly can. You would also remember we're a bit earlier, so now I really wish we would have just started a bit earlier, because this is the platform where we would like to receive responses, and whatever you then leave out, if it's really very little, you are welcome to send those as further written responses. But at this point in time, let's just pick up on the time, and I will probably allow you another 5 minutes or so. And if you can maybe also just remove that screen, it is quite busy in front of our eyes. And secondly, also to switch on your camera so that we be able to see you, since it is being broadcasted. I do not know who Nawi is. I will just inform Nawi that we do not take questions apart from getting the responses and presentations from those who are called to present. So you can please lower your hand. Continue, Ms. Jordan.
Okay, Chair. We are happy to answer as many questions as we can answer. I'm just struggling to unshare my screen and then just continue the Zoom. Can I just change the slides instead?
Yes, you're welcome.
Okay, and now I can put my camera on. Okay. And we are happy to answer as many questions, but we don't think 20 minutes gives these kind of questions justice, and so we would request for a written submission if this is allowed after the interaction. If really what People's Health Movement is valued, then we would really request for such.
Yes, please continue. We'll appreciate it.
Okay. Sorry, less busy slide. My camera on. Okay, so I'll just give opportunity to some of my colleagues. I know that there's Lauren on the panel that would like to respond. I know Ilroy as well would like to respond. Lauren, would you like to start with a few questions with the camera on?
Thanks, Sinesipo. With the permission of the chair, I'll try to answer some of the questions. Okay, thank you, Chair, and good afternoon to everyone. So I think one of the things to say is someone characterized our view as thinking that the public sector is broken and the private sector is perfect. And I think maybe a good starting point is to emphasize that our perspective is that the public sector actually does very well with the limited resources it has, and that I think one of the concrete illustrations of this is the COVID-19 pandemic, where the public sector has done very well in responding to the crisis. The point we're trying to make is that compared to private sector sites, public sector sites are often under-resourced in terms of staff and also infrastructure. And so what we're advocating for is that under the NHI, resources should, as part of the NHI, be invested in strengthening public sector facilities and also increasing the human resource complement at public sector sites, because this would help them to get registered as designated providers. And of course, a key part of strengthening public sector sites is bringing in community health workers as paid employees that have regular contracts and good working conditions. We know that community health workers are advocating to be employed as public sector workers and not appointed on short-term precarious contracts. So it's really not the case that we see the private sector as perfect. In fact, we are strong believers in a public health system or a health system led by the government for the public interest, in which the public sector provision plays a dominant role. So that's in response to one of the questions. Then in terms of the single purchaser, won't it create a monopoly? We know from research that the Competition Commission has done that the South African economy in general is highly concentrated, and that this trend has deepened over the past couple of years. The Commission, I think, reported on this just recently. In the health sector too, the for-profit sector, the health market is very concentrated. And we had the Health Market Inquiry reporting on this, I think, at the end of 2019. So certainly one of the benefits of having a single purchaser system could be that you have a purchaser that's big enough to actually drive down prices and to ensure fair pricing of medical services in both the public and the private sector. And so I think this is something that one should take on board in thinking about why a single purchase system could work. And besides that, there is a lot of data, lots of research that shows that a single purchase system, has much better outcomes. Yes. Okay. I think. And then just on the distinction between primary care and primary health care, the point we're trying to make is that primary care is, and yeah, I hope I don't get confused myself, but my colleagues can come in to correct me, that primary care usually refers to care at the point of care, the site of care that's closest to the patient, and there's a certain basic package of services. But what we try and point out is that there's this other concept, primary healthcare. And primary healthcare is slightly different because it also says that, yes, it's good to have primary care, but a primary healthcare system, which is what is referred to in the NHI documentation, primary healthcare means that we also have to look at the bigger structures, so the social structures, the economic structures, that drive poor health outcomes and that make certain sectors of the population more likely to be sick, and once they're sick, more likely to be unable to access treatment. And so a primary healthcare approach wouldn't only emphasize good quality care close to patients, but also a complete rearrangement of the social, economic, commercial structure to ensure that this can actually take place. So if with the chair's permission, I'll hand over to Noe, who will take the question on civil society participation. Thank you.
Hello, can I come in? Hello.
We can hear you.
Yes,
Afternoon, everyone.
Now you can come in. Thank you.
Okay. Yes, my name is Noe from Fukuletu Health Committee. I've been listening to the question about the community participation and how health system is doing about interaction when a lady was asking of saying that it seems that everything is well. As Usune Sipho has elaborated and said the timing is not good, all those questions we need really to answer it in the manner that, because it's something that's eating us as a community. Community participation, first of all, as we are health committees that are appointed, that apply, we represent a community. So doing monitoring and evaluation, when you mention that how many clinics, if it will be PHM that is doing it or implementing a health system,
I suspect that my colleague
so
might.
that's supposed to give you. Hello.
Yes, you're back. Please continue.
How do you interact with your official that's supposed to give you a report back on the health system, on determinants of health, on the right to health that are happening in all the clinics? Because you're the one that's supposed to answer the question you ask to the speaker that was presenting. And another thing, the policies that you are doing and said you are meeting with health committees, which health committees that you are meeting with when you doing all those policies? Because we are facing problems in our clinics. We never see you in these problems that we are facing. That is why as Ikukuletu and other Cliffontein sub-district have all these problems that we need to sit down with you and answer. When we give a presentation as UPHM, as clinic committees, as even now, you appointed health committees. You never even give us induction workshops. You've been appointed as more than three months now. We are just sitting and folding arms because we are representing community. Our interest is the community. In all the questions that those questions that you answer, you're supposed to answer those questions because we are waiting on you. Because if you are talking about DUHC and we talk about the NHI, that we are in favor of NHI because we need everyone to have right to health. So we have to implement. As the government of East Western Cape, we're having a lot of problems. I don't see you answering question on a presentation that how PHM is going to implement it if it was PHM that is on government. So give us more time. We need to answer this question in the right manner.
Yes, now can I stop you there, please? There's a point of order, but I've been muted by my host when I wanted to interject.
Okay, come with the order.
Honorable Sukacha.
Susan, I don't understand now what is happening. Seemingly the team is asking questions from us and they're talking about the Western Cape government. And can you please clarify what is the aim and objectives of this platform, Chair, please?
Yes,
Sorry, Chair, could we interject?
No, let me speak. Thank you very much. I think now he is addressing concerns on the wrong platform. This is not a Western Cape government. This is also not a place where we do appoint street committees.
Chair, can I clarify?
Yes, but let me finish. This is also not a place where we appoint anybody, so you can clarify, but I needed her to hear it. And then if you can please continue, Sinesiko. Thank you.
Yes, I just wanted to clarify what Comrade Novi was emphasizing, that we are happy. It was particularly about the number of questions that were asked and also the amount of time that we're given to answer the questions. We want to engage fully with those questions and we want to respond to each and every single one of them, but we strongly feel that the time does not allow. And we beg the committee to actually give us an opportunity either to make a written submission on all those questions so that we can actually clearly voice our views. Particularly, that's the first point. Second point, particularly on community participation. PHM We submitted our responses to the white paper, green paper in 2016, only to be invited 5 years later to a participation on work that we did 5 years ago. Some of the people that worked on the project are actually not even members anymore, or they've moved to different platforms. So what we're emphasizing in terms of community participation, and this came with with the clarification from the last question, to say what is this rubber stamping and what is this tokenism. If I have to remind the panel that there are 3 levels, or there are levels of participation. There's non-participation that comes with you either get informed, or you get therapy, or you get manipulated, you get told what to do. And this is what Keda Norway she is the point that she's trying to raise, that often the participation, even including the NHI bill participation, it's a people that get informed. For example, when the NHI bill was formulated, there was no community participation. Particularly with the bill, we were handed the bill after it was produced. And so what PHM was actually advocating for was, in the process of drawing up the bill, who from the civil society was included in deliberating on what contents the bill should have.
I would have to interject now, Sipo, because you're saying some wrongful things. It's important that I do. Please do understand that it's the wrong platform that you say. You must be advised. No, let me finish. You must be advised that there was a green paper, a white paper before they became an NHI. And it's also not true that it's 5 years ago. In 2019, we had called for these submissions. And it's only then that it came to our portfolio committee. But I tell you what we will do. Since we have now run out of time, and you're correct, it's a lot of questions. And I did say you can answer as many as you possibly could. You are very welcome to give us written replies. I hope you've been able to jot down those questions so that you're welcome to send it to us. Our committee secretary is on the platform, and I'm sure she's also the one who had been in contact with you. And I really hope from my heart that you understand what I am saying with regards to the process and what our role is. I really hope so that you don't go away from here feeling that we've not treated you well. It's not the intention. It's purely to say that what is raised is not the platform where it's raised. This is a National Assembly Portfolio Committee on Health, where we've called for inputs from society on the National Health Insurance Bill, which you have done in your presentation, but you say you need more time in order to be able to respond to the number of questions which were raised. So we do appreciate it. I'll give you another few minutes to
Chairperson. I'm sorry to speak after you have spoken, Chair, but I'm a bit very worried, Chair, because it's clear there's a lot of misunderstanding between the team that is now presented and what our role is as a portfolio committee. We are not government. We are not government. We are an oversight body. This initiative of having public hearings, we did go out to communities and have public hearings on the NHI bill. And the team that is now presenting indicated that they would like to come and do presentations themselves. That's why we gave them an opportunity to come and do presentations. They would never see us coming and talk about the implementation of community healthcare. That's not our responsibility. That is government's responsibility. We are an oversight body. We go out and see what government said they are going to do. Is it happening? That is our responsibility as an oversight body. So there's a lot of unclarity here when the speaker before, Comrade Jojo was mentioned. I was very worried when that speaker spoke. It's clear there's a lot of misunderstanding that needs to be cleared. And you are quite correct, Chairperson, the timing is not an issue. A lot of people, you are not the first ones that came and make presentations. There are a lot, it's about 120 of you guys who came and made presentation. And most of them, if time is against them, they make presentations in writing. they answered questions in writing. There's nothing wrong in that. So comrades, I don't know, you said it's a comrade, the one before you. So comrades should just understand that distinction between us and what our role and responsibilities are. Thank you very much, sir.
Thank you very, very much, Honorable Sukacha. I am going
Honorable
to put the following. Honorable Paulus, no, this is not the platform for this. I'm the chairperson of this meeting. You are doing something that is not correct. Would you allow me to speak? And then what I'm going to tell you what my ruling is. I think you have a misunderstanding of our role and what we are doing here today. And I've tried to indicate that as well as Honorable Sukacha. So I'm going to give you 5 minutes to Sinesipho. She can decide who she wants to speak. And then after the 5 minutes, you're very welcome to answer all of your unanswered questions. You can write to us as the committee through our committee secretary, and we will certainly have a look at your responses. So thank you very much for coming. I'm handing back to Sinesipho, and she can decide whom of you respond on PHM's behalf. Thank you.
Thank you, Chairperson. We just wanted to confirm whether or not we would be able to get a recording of this event so that we can actually, we jotted down some questions, but because of the pace, some of the wording we didn't get, we would be able to get access to the recordings so that we can answer those questions in a written form.
Well, it's in the public domain, so you can write to our committee secretary, and she would surely also then consult with me, and we will see to it that you do get those questions, so that you're able to respond better if you feel that there were too many questions asked.
There were not too many questions asked. It's the quality of questions that were asked. We want to respond to the quality with the same quality.
Yes.
And I think possibly we had the wrong notion coming forward to engage really with the government on this particular NHI bill. We were under the impression that this body represents an oversight that will communicate the needs or the concerns of civil society to the government in terms of the NHI process. That was our understanding coming forward. If we were unclear or wrong in that, our apologies. But maybe it's just that this is the first time that we've had an opportunity to really express the concerns that we have over the NHI bill, over the private sector involvement, over poor lack of community participation, and over just the overall process. I think I would just give my last comment to Keda Ilroy, and then we can close, and then we will submit a written response.
Thank you, Sinesipho, Dr. Sinesipho Jojo. Thank you, Dr. Kenneth Jacobs, honorable members of the Portfolio Committee for Health. What I was going to offer and say is wearing another hat, namely as treasurer of the Parliamentary Monitoring Group, I could ask the staff of PMG to expedite the minutes of this meeting that we also take so that we can speak off the same page. We are very passionate about these issues. I don't think I want to answer some of the questions that were raised. There were many, and I don't want to highlight one. However, be assured that we're going to have a detailed written response, and with your permission, Chairperson, we would like to engage the committee in a manner that helps explain the passion you see from the members, because we are very, very committed to making human rights real in South Africa. Thank you.
Thank you very much. Let me take this opportunity to welcome yourselves, PHM, to have done this presentation. I have offered yourselves to get to speak to our committee secretary, and I'm sure you have the contact details that you'll be able to then send those replies to us. Thank you very much. We will now move on to our next group of presenters, which is the Professional Provident Society. I do note that we have one name of the names have been given, Ms. Simi Basudev on the platform. And I think there was to have been a Ms. Ayanda Saboni also, and I've not been able to have a look. So you're very welcome to show yourselves. Please do switch on your cameras when you speak. Also indicate to us, whoever is leading yourselves, to us who your team is, and then go straight to your presentation. Thank you. Is PPS present on the platform?
Yes, they are present, Chair. I'm not sure what is happening with Ms. Siboni's volume.
Chair?
Thank you very much.
Oh, okay. Sorry, I wasn't coming through. Thank you very much, Chairman of the Portfolio Committee. My name is Ayanda Siboni. I'm with my colleague Simi Bima Basedev. We represent PPS, the Professional Provident Society, and I'm going to just put on my presentation to share on the screen.
Good afternoon, Honourable Chair and members of the Portfolio Committee. I thought I'd just introduce myself while Ayanda is putting on her presentation. Thank you.
So thank you very much for this opportunity to come back and give our views to this committee. We were given an opportunity a few months ago to engage, and we're going to pick up the conversation from where we last left it off. Just to recap who PPS is. PPS, we call ourselves a voice of graduate professionals. We are a financial services company, diverse financial services company that is in insurance, medical aid administration, investments, among other businesses. Our membership is made up of graduate professionals, that is anyone with a 4-year degree. Our roots are in the medical field, but now we take any member who's got a 4-year degree. So we operate under the ethos of mutuality, which means that our members are the shareholders of the business. So we are not a business that has got one shareholder, but it is a business that is owned by all the various members. Our membership, so our members is stroke for our clients as well. So our membership is a plus minus 150,000 members, and of those, about 30,000 are members in the medical profession. So where we get our mandate from is from these members, because we engaged with them as far back as 2019 to do a survey to find out what were their feelings around the NHI and what were the questions or the issues that they wanted us to take forward with the parliamentary committee around NHI. Another thing to note is that our members do represent a big portion of the supply side of health services. Besides the technology, they represent a big portion of the human capital that is involved in health services, and they are a significant tax base. So you know, they are users of the tax service of the health services, but they are also contributors in terms of being providers of these services. So at our last meeting, there were some items that there were a couple of questions that were given, but 3 of these questions are the ones that we sort of want to go into and perhaps have a discussion about. One was the inequality of access to services. We were questioned around that. You know, were we of the view that the levels of inequality should proceed? And we did explain that no, that is not what we are about. We think that we agree with the principles of universal healthcare and for all South Africans to have access to good healthcare. However, we obviously have some concerns around how that is to be implemented. So this is what we're coming to the party to provide solutions around. The second one was there was a question around the sustainability of the current system. And we acknowledge that there are things in the current system that need to be changed. And that's what we're going to speak about, as well as the health market inquiry. There was a specific comment that, it's not only imperfection on the public sector, and we did admit that the private and the public sector have got areas that they can improve on to make our health system work a lot better. So what we do like about the concept of universal coverage, one is something that is aligned with the United Nations Sustainable Development Goals, which is all countries are aspiring to do this. And we support this because healthcare is a universal right that everyone should have access to. Secondly, we also think South Africa has already got a form of universal healthcare in place. The South African state, unlike some other countries, does give access to everyone in the country, regardless of your resources. And we believe that this is a commendable achievement because in South Africa, whether you have got the money or not, you can get quality healthcare. However, the experience, obviously, in the private sector and the public sector can be quite different. And then universal healthcare will increase employment in the health sector if it is implemented correctly. And we believe that this will help with a lot of the strain on human resources that are currently working in that sector when NHI is implemented. And it can also create opportunities for sustainable healthcare provision between the public and private sectors. And we feel very strongly that the way that NHI needs to be implemented needs to take into account the role that the private sector can play in augmenting the system and making the system stronger. So we do not believe that NHI is an either-or solution. We believe that it's a solution that should embrace the private sector, the technology, the practices that are there in the private sector should be included as part of the system so that we can build a system that is best for South Africans. Okay, so in terms of inequality to access to services, our position is that access to service should be for all. And we believe that the current system does create a level of access, but there are obviously some resourcing issues in the public facilities. Our proposal is that the health system should be optimized and improve service for everyone who is a South African. So not taking the system and throwing everything away, but taking what is currently there. And let's work together to improve the current public health system and the current private health system and make these two work cohesively together. It's not, we don't believe that, having a new system that says, single payer and we discard all the learnings over the years that have been acquired in the private sector is going to be in the interest of South Africans. Another thing is that in terms of equality and access to services, citizens in South Africa are already paying for the current health system. So they are already, from the tax resources, the public health system is already being funded by individual citizens. And the amount that they are using over and above for private healthcare is discretionary income. And in a country like South Africa, a democracy, people are allowed to spend money however they feel. So we believe that the taxation that is being used to fund public services should continue to fund public services, and we must optimize, work with the public sector, work with the private sector. And if people feel like they want to spend more money on private healthcare, they should be allowed to spend more money on private healthcare. I'm now going to hand over to Simi to pick up the next section. Thank you.
Just highlighting sustainability of the current system, affordability still remains an issue for members of medical schemes, and sustainability in the long term is questionable. The private sector is, however, supportive of the NHI from an NHI perspective of improving primary health care for all. Corruption still remains a challenge for both private and public health care. Therefore, without fixing the issue of corruption, no system will be sustainable. We have a shrinking tax base, which has worsened during the pandemic. Thus, overtaxing people will lead to immigration or worst case, tax avoidance. There is no them and us. We must find a solution for all South Africans in general. Next slide, Ayanda. So to touch base on the health market inquiry recommendations, which is now over 2 years old, to date, unfortunately, there still has been no response to the recommendations of the HMI regarding the proposed operational reforms. Adopting the HMI recommendations can build a range of institutional and individual capacities to manage healthcare provision in South Africa. HMI explicitly takes NHI into account in designing its recommendations, putting forward suggestions to create a better environment in which NHI can function. The recommendations aimed to ready the private sector to operate as part of NHI, enabling the private sector to integrate into the NHI system. And we've actually already seen some of this happening during the pandemic. Next slide. Now, since our last meeting, COVID-19 pandemic has come full circle. We have all seen the need for coordination and cooperation between the public and private sectors. We have seen firsthand the shortcomings of the system and elements that we can build on. The control environment was a glaring area where tighter controls were needed. Procurement was a challenge, even in our response to the COVID-19 pandemic. On the technology front, we have to commend Department of Health on the successful implementation of a centralized vaccine registration and certificates system. And this really is a good step in the direction of an NHI where there's one platform for all members and all their healthcare information on a single platform. So clarity is needed on the following, and this was what we highlighted at our previous submission. The time frame of the initial phase, measures of success, what is in scope and not, what is included in the benefit package, review of governance structures, including focus on corruption and fraud, review of the role of medical schemes, specifically clause 33, where we see a future of both NHI and medical aid schemes. In addition, next slide. We await updated details on the basket of services, details regarding the funding. Funding is foundational to the success of the NHI. Without clarity of how the economics work, the system is doomed for failure. What is the role of the current administrative infrastructure in the world of NHI? Has the viability of a single purchaser been tested? And these are some of the clarity or questions that we had asked previously, and yet to date, there has not been answers to this. There have been lots of discussions around this with the various presentations to the portfolio committee, and we are hoping to get answers to some of these questions. Ayanda? Ayanda, you're on mute.
You would think after so many years of us working on Zoom, one would not go on mute. I see there is a hand. I'm not sure, we were not yet finished with our presentation, so I'm not sure, Chair, if we answer questions now or we finish the presentation first.
Please continue, I will find out. Thank you.
Thank you. So from a taxation perspective, professionals want to know how the implementation of NHI will impact their taxes. They want a level of certainty as to what does this mean. The highest tax bracket at the moment is sitting at around 45%. What does this mean for individuals? Because when people are overtaxed, it does lead to a situation that is actually not sustainable.
I saw it.
High taxes encourage globally mobile professionals to move to other geographies. So we already have seen that there is a challenge with immigration. In our own stats as PPS, we've started to see that there is a trend around professionals moving to other geographies. And obviously, as South Africans, we do not want this because we want to keep the skills in our country and we want the professionals.
Chairperson.
Sorry for interjecting. I have to take that hand. Honorable Munyai.
Honorable Chair, I have the similar presentation that I received on the 22nd of July. I mean, why the same organization will present twice? Exactly the similar presentation. Why twice? If you can be clarified, because I have the similar content of the presentation, which has been presented. Is it a rule in Parliament that they should, every organization must come back twice? If I can.
Yes, thank you very much. We hear what you are saying, Honorable Munyai.
The Secretariat help us, Honorable Chair.
Give me a moment to follow up with the Secretary of the committee. Honorable Van Staden.
Just to help, Chairperson, isn't it possible that my colleague member Munyai get a presentation from the email site which we were using when we started with the process? I'm just asking maybe to clarify the problem.
No, I'm not confused. I know you can ask them. Here they are.
Well, I don't know about that. I know I haven't seen it. I know there was one or twice when I was not present, and I could have been.
The Honorable candidate is presenting here now.
Yes. Now allow me to address the problem, please. I am saying from myself, I hadn't seen it because I know there was once or twice that I was not on the meeting, on the portfolio committee meeting. So I'm going to call our our portfolio committee secretary. If you don't mind, just hold on a little while and I will find the reason if it is such that you are here twice, and we will then attend to the problem. Thank you very much.
And Chair, I'm sure the presenter can also clarify to you.
Please do, please clarify, but allow me to do what I had asked or inform you that I would do. I'm going to call the committee secretary. I am saying that I have not seen it, and if it is as such, we will address the problem. I will ask the presenters whether they had presented before, but let me then first ask them and then call the committee secretary. But yes, I see Miss Simbi Bima, who has another surname, Bastudev also. I so see you shaking your head in acknowledgement.
Chair, Honorable Munyai is correct. We were invited to present. As I mentioned, we have been invited to present before. And the reason why we're here is because we're invited to present again. So we would love to reiterate and share the views of professionals with the committee.
All right, so there could have been a bit of, maybe I'll just ask, let me make my phone call and find out. So give me a 2-minute break. Thank you very much, Honorable Munyai, for picking that up. And thank you very much for your acknowledgement that you had presented to us before. According to Honorable Munyai, in any case, it's the same presentation. And to be fair and correct to everybody who is coming to present, our secretary does say that there were two submissions from yourselves as PPS. There was a written submission and there was an email submission, and that is the reason for the confusion. And then it was viewed as two different submissions. So in the context of that, I apologize to yourselves. I apologize also to the members of the Portfolio Committee, and I will then ask you not to continue with your presentation, and we will then also close our meeting.
Thank you to the Portfolio Committee.
Thank you very much. Honorable members, that does mean that we have come to the end of our presentations for today. We are looking forward to the presentations of tomorrow. I might just get the exact time, and I think it's at 10 o'clock tomorrow morning. I didn't have time to go and look up now, in case you need to be reminded. I know it's 10 or 10:15 or 10:15 in the morning that we will continue with the work of this very important Portfolio Committee. Thank you very much.
Honorable Chair,
Yes, Honorable Munyai.
tomorrow late I have to fly to Cape Town as we're all required to be in Parliament on the 10th seated. So I'll have to fly tomorrow night. There's no other day. Thanks.
Yes, noted. Thank you, Honorable Munyai. I'm trying to find that program now on my emails so that we can just go directly to. Yes, Ms. Majalamba.
We are starting at 10:15 with James. Thank you, Chair.
10:15 with James. Thank you very much. Honorable members, that brings an end to our meeting for today. This meeting is therefore adjourned.
Thank you, Chair.
Thank you, Chair. Thank you, Chairperson.
Recording stopped.
Thank you, Chairperson.
Chairperson.